Hi there.
Hello.
How was, oh, Val, I love your look. You look so pretty.
Thank you. You look pretty too.
Thanks.
Belle's got the curls going.
Yeah, got the curls. It's like coming back from vacation, you know? So it's like, you got to do it yourself. That's
There
all
you
I could do.
Right? That's true. Vacation is the ultimate DIY. Good
Absolutely.
luck with that. Oh my God. We'll wait a little bit. People coming in. Hi, Eva.
Hey, how are you?
Joanna.
Hi there.
Yeah, I have a little DIY going on myself, Val.
Oh, yeah. I mean, a girl's got to do what a girl's got to do.
Got that San Diego salt in your hair.
Oh, happy birthday to Jonah.
Happy birthday.
Thanks. You guys are so sweet. I love the messages. I'm lugging stuff out. But all the whole garb, of everything, screaming, I love my baby. It was so much.
That's nice.
It was good. How are we doing, everyone? Coming on?
Hi, Eva.
Hey, Anna, how are you?
I'm good.
You look fantastic.
Oh, thank you. Thank you. Thank you.
Hi, Nancy.
Hi, hi,
Welcome on. Nice to
How are you,
see
Wendy?
you.
and we need to talk about me next month. Is there?
Next month. Okay.
Yeah. Did you get my message
Well, let's talk about it.
later?
Yeah.
Oh, after the end.
I've been out. No, I was out. I was on a little beach holiday, so
Oh, nice. Good for you.
I didn't get your message. But hey, there she is,
So,
Chisana.
okay, so when will you get back to me?
Welcome.
At the end, my dear, or when can you get back?
Yeah, tomorrow I'll give you a call.
Okay, that sounds good. You got my number,
Yes.
and my email.
I
Okay,
got your number.
thank you.
You're
All
welcome.
right, and-
Nice to see you.
We're excited about tonight.
Oh yeah, we are too. So I'm gonna just kind of slowly get started as people. Hi Keith, how are you? I'm gonna slowly get started as people are coming on. And I just want to welcome everyone to episode 8 of GDerm Fresh, which is the virtual meeting of Generational Dermatology Symposium. And as it stands, we will be live February 18th to the 22nd in 2022. We'll be at the Omni in Rancho Mirage, the Omni Hotel. So please, stay with us, and we want to see you there. And we just love for everybody to come out to this meeting because we have so much to celebrate, and it's just going to be a wonderful live meeting with all of the speakers that you've been hearing all year long. As you know, this was really a response to COVID, and we had to do a pivot. And it's been great because we've really built a community, and it's just been contagious, and new speakers, new subjects, new content. It's just all been really, really a wonderful journey that will culminate in our live meeting of February. So generationaldermatology.com, that's where you can find out all the information. And August is Hair Awareness Month. So for those of us who love hair, we've been waiting for August. And it's finally here. And so excited. I saw Dr. Kogan. She was just here. I just saw you on the screen. Hi, Sophia. And I like to thank we've had so many wonderful sponsors throughout this whole, these months of GDerm Fresh. And tonight we have 2 sponsors. And I'd like to start by thanking them both. Lana Kerr from Lumisk, thank you for your sponsorship. And
Yes, of course.
I'm going to see a really neat video of another hair use for CO2 lift, which is going to be kind of exciting, and I'm very excited about the use. And then we have Dr. Sophia Kogan, who's going to speak to us later. And she's representing Nutrafol, and we love Nutrafol. So Sophia.
Thank you. Hi.
Thank you, because as you guys know, without our sponsors, the education gets limited. So without them, we really can't, move along. And I think that's it. Just remember, this is very informal and casual, and use your chat boxes to ask questions. We'll get to your questions throughout the evening. We have an amazing faculty tonight, which is why we have so many registrations. Dr. Val Callender, Dr. Shoshana Kindred, Dr. Neil Sadek, and Dr. Sophia Kogan. So, this group owns hair. So if there's any question you have about hair, tonight is the night to ask it. It will be answered, all right? And we will deliver. So I'll take the first slide. I'm just gonna set the stage because I'm not gonna speak much, but I wanted to kind of set the stage. And this slide, if you guys haven't seen it before, is just about the decades. And this is what this meeting is about. It's about the generations, and it's about looking ahead and making plans of prevention for your patient, right? I always say, you've heard me say it, if you know the train is coming into the station, i.e. hair loss, i.e. Whatever, melasma, rosacea, and you know it's coming for you because you're genetically predisposed, you're in an environment which is going to contribute to it. If you know that it's coming for you, why wait for it to come? Get preventative, do what you can for your patients, and practice more on a primary and secondary level of medicine, and not wait for the pathology to present itself. Because I think we owe that to our patients. We're smart, we've all trained, so long that we can think about strategies, how to keep our patients out of some of these disorders that maybe we can prevent. And that's what this is all about. So I'm going to talk a little bit about hair anatomy. We don't talk about that much, but I think it's important because when you look at hair, and we have a huge toolbox for hair, and what we use really depends upon the disorder and what the pathology is. So here we see a live hair, and we see our hair shaft emerging from the skin. And we know that our hair shaft is keratin, and made a lot, not only of keratin, but really important, and this is important in therapeutic, it's sulfates. So a sulfur diet is really important because we always think of hair as keratin, but it's also the sulfur. And remember those disulfide bridges, and there's a lot of sulfur content in here. So we want to think about that when we're making dietary recommendations to our patients, and also asking actually those kind of questions, what kind of diet are they on? Next, when we go down to the sebaceous gland. And remember that any sebaceous gland pathology that you have can lead to loss of hair, which is why many of our patients on Accutane, right, which diminishes the sebaceous gland, start to get hair loss. So this, we're not talking about Accutane today, but just remember that the hair follicle is kind of like a mini organ in itself. And things that affect the hair follicle are going to also affect hair growth. So, remember that hair loss can happen with any of your oral retinoids. And that sebaceous gland hypoplasia is part of the reason. And then we see the bulge area. We hear a lot of talk about the bulge. The bulge is really important because that's where our germinative cells come from. And without a bulge, you're not making new hair. So those types of things that will create new hairs, for example, injections of PRP, you want to make sure that you're deep enough in the hair to get to the bulge, because that's where you want those cytokines. You want them to go to that bulge area, and that's what's going to stimulate new cell formation, and then the bulb. And as we know, when this whole structure is destroyed, and burns and inflammation and other disorders that we're going to talk about today, then we are unable to generate a hair. So depletion, especially of the bulge area, is going to lead to hair loss. Next slide. And here it is in schematic, and I pretty much went through it, but I just wanted to show this. It's a really complex network. Oh, I know what I wanted to talk about. On this slide, I wanted to talk about circulation, because circulation is really important in hair growth, and we don't speak about it a lot, but yet many of the therapeutics that we have are circulation based. For example, minoxidil, right? We don't know how minoxidil works, but one thing we all do know is that minoxidil increases the circulation, the microcirculation to the hair. And as we see here, that the hair has muscles, there's nerves, there's a lot going on. The hair is like a mini organ. So anything that increases blood supply is going to be beneficial for hair growth. Conversely, anything that diminishes blood supply can also be detrimental to your hair. So we see in a lot of, cardiac patients, patients with compromised circulation, that they may also have concomitant hair loss. So I just want everybody to kind of think about that. And another example, if you can go way back to medical school, when we used to study, nevus flammeus and all of those disorders, those hemangiomas, and remember on the legs of people, what you would always see in addition to the hemangioma, you also would see hair, right? Lots of hair growth, because circulation really augments hair growth. So in our plans, we want to think about our circulation and what is the circulation of our scalp. Next slide. And here are just, kind of our therapeutic toolbox, why things work. In lichen planopilaris, it's fibrosing. And some of the things that we treat it with are things that we treat other fibrosing disorders with, like methotrexate, like cyclosporin, because they reverse fibrosis. So it's no different than the hair. And CCCA, we're going to talk about that a lot later. Basically, the pathology is inflammatory. No wonder why things like doxycycline is key in treating CCCA, along with corticosteroids and platelet-rich plasma. Telogen effluvium is a cycle alteration, often induced by stress and medications. And that's why Dr. Kogan's going to speak to this later, why micronutrients, supplements, and nutritionals are so important in effluvium and getting our hair back on cycle. With male and female pattern alopecia, the cause of that, of course, is aging, hormonal, and also, again, microcirculation alterations. We can age reset, meaning we're going to reset the age of our follicle with exosomes, which are little packets of mRNA, which help the hair reset age-wise. We have PRP, which again does an age reset on the hair. And then we have those pro-circulatory things that we spoke about, minoxidil. I'm going to show you a video of CO2 lift today, which is a topical carboxy therapy, which is being shown now. And this is red hot right as like of now, which is being shown to increase hair circulation. And we don't really understand why, but it probably is because of increased circulation, because that has been proven on tissue, on skin tissue, as well as mucosal tissue. Topical carboxy therapy increases circulation. So, not a surprise that it may be another tool in our toolbox for hair loss. And I am using it a lot for that, in addition to everything else I'm doing. And then, of course, for the hormonal, those 5-alpha reductase inhibitors. Traction, is due to a lot of follicular weight, tension, and inflammation. We change our hair habits, PRP again is like CPR. I call PRP like CPR for the hair follicle, right? It just brings in oxygen and circulation. And then our diffuse alopecias, a lot of times your medications and endocrine. And again, we have to increase our circulation in PRP. I think I have maybe one more slide before I'm done on this. Oh, this is a video of the CO2 lift, and I am using it on a case. Derek, we could start the video. And I'm needling. This is my typical case that I'm doing every day. So this female had traction alopecia, and from hairstyle, hair grooming practices, ponytail, back in the day, getting the edges flat with the straightening comb, and et cetera, et cetera. So I did microneedling, and I also did a depot PRP. And then after I was done, I applied the CO2 lift mask and left it on her scalp, and I send them home this way. So they go home, and then they and it's kind of nice too, because it contains all the blood and all the, the mess that you're doing on the scalp. It kind of contains it. I send them home, and then I wash it off, have them wash it off the next day. So just again, another tool in the toolbox of hair growth. Okay. And what's this one? I think is anyone going to show PRP? Derek, can we fast forward like to about 40 seconds in this video? This is a hair transplant I was doing. This is a FUE case. I know Neil's going to talk about transplantation, but you can see go ahead now. This is the recipient area. I'm injecting PRP. So you have to be careful, because you can't, you have to put the PRP in before you actually put the hairs in, because you don't want to push out the hairs by injecting the PRP. But I love doing hair transplantation cases, and I love doing using PRP. So again, PRP is bringing in, nutrients, all those great cytokines, and circulation. And I think it really helps the cases do better, as well as been shown to show that the grafts do better, because the grafts will dehydrate if they're not, if they're just sitting out in saline, but they're just a better graft.
They can be used, Wendy, in the donor area as well. So, in both the donor and the recipient areas.
Hi, Neil. Yes, absolutely. Excellent point. Yeah, use it. You use it throughout everything, right, Neil? Like you soak them in it, you put it in donor, recipient. It's just like in all stages of the case, correct?
Yes.
Yeah. Okay. Next slide. Okay, here we go. So now we're going to hear from Dr. Callender. And Dr. Valerie Callender is a board certified dermatologist who's known for her sensitive and cutting edge approach to the management of hair loss. I mean, Val has been out there way ahead looking at hair loss, and one of the original people looking at CCCA, describing it, observing it, and going about treating it. She's the founder and medical director of Callender Dermatology in Washington, D.C. area. She's professor of dermatology at the College of Medicine. She has many awards. She's received the President's Award and the Mentor of the Year Award from the Women's Dermatologic Society, and the Clark Bitterroot Award from the American Academy of Dermatology, Dermatology Foundation. She's been president of the Women's Dermatologic Society. She's also a past president of the Skin of Color Society. Always involved, always right on trend. And we can't wait to hear from you today about, I asked her, I wanted things like a lot of conversation. So we thought we'd talk about some cases. So welcome back. And most importantly, she's one of our favorite GDerm faculty.
Oh, thank you, Wendy. So I definitely want to hear from, the other panelists about how they approach these cases, because I was told to, let's, make it a little case-based. So I'm gonna share my screen, right? Okay, and then I have to, I think go over here and then go over here. Let's see.
Click on
Okay,
that again, Valerie. Dr.
I got it.
Perfect.
Is that good? Okay, so let me see if I can advance these.
You might have to reshare because you're just sharing your desktop at the moment.
So what do you mean by reshare?
Like stop sharing and then click share again and share the PowerPoint.
Like that? But now I can't see everyone.
Click share screen again
Uh-oh.
after the PowerPoint is started. The
Try again.
Yep. Perfect. Now if you hit slideshow and start it, you're good.
Okay, let's see.
Yep, you're exactly where you're supposed to be.
Okay, great. So we know hair loss is, for me anyway, a very common problem, particularly in women. It's mainly seen in men. It's more common, but I think it's more devastating in women. And we all know that when women have hair loss, it's definitely an emotional journey for them. And so I think it behooves us to be able to be very sensitive to these patients. They're going to be long visits, especially if it's the last patient on the schedule. You're going to be in that room for a while. But empathy as physicians is very important. And so to treat hair loss in women sometimes can be very difficult, but it's a very important, I would just say it's just very important for us to be considerate and make sure that we do the best. And I think what's really important for most patients is that we understand that a diagnosis is what we're here as dermatologists to do. There's so many patients who will come in the office and say, oh, I just have alopecia. And then when you ask them, do you have a diagnosis? Do you know exactly what form of alopecia or hair loss you have? And they're like, no, the doctor just told me of alopecia. So I believe that every single patient who's in your office needs to leave that exam room knowing exactly what their diagnosis is. And then a thorough treatment plan must be given to them so they can go on their journey, hopefully to regrow their hair. So hair loss, as we know, affects the quality of life of our patients. We do know that it's more profound in women, and women suffer with hair loss issues as far as anxiety and low self-esteem, more so than men. Then it's true also, younger you are, it's more devastating to you. And also if you have a scarring type of hair loss, it's also more devastating. So it's reported in the literature. We know that it's an issue. So quality of life is definitely important for us as well as for our patients. And so we definitely need to make sure that we start early and diagnose these patients and get them on a good treatment plan. And this is what we try to do. We try to prevent our patients from going from this grade 1 to grade 5. And so our job is to, again, that early intervention, begin treatment and try to stop the progression. We know that with scarring alopecia, it is a form of permanent hair loss. So you're not going to be able to rescue every single follicle, but the goal is to stop the progression. And I always tell my patients, my ladies, that we need to hold on to what you have, because we know that these conditions are progressive and will destroy everything in their pathway. So what do we do in the exam room? Definitely, the evaluation of hair loss is important, and to listen to your patient. So there's certain questions that we all should ask. I'm not going to go through all of these, but I think the main points I always kind of focus on, because again, we're on a time limit when we're in that exam room. So we got to get in and get out sometimes. So it's always good to make sure that how long it's been going on, whether they're complaining of the hair just thinning versus is it shedding or they're having breakage. And sometimes they can have all of the above. But you really try to then figure out what your diagnosis just from asking that question. And then, of course, the pattern. I mean, is it localized, is it diffuse, and if they're having any symptoms like itching, burning, etc. And then, of course, the regular history, you want to make sure that you ask your patient about their medications and any illnesses, whether it's runs in the family, any nutritional dieting that they may be doing, and of course, their hair care practices. The examination, again, to be able to really examine a patient, it's great to have them sit in the chair so you can stand over them. So you can really get in and part that hair. And it's really important to get in there and make sure that you examine the scalp and the hairs, do a hair pull test, use your dermatoscope, look at the scalp, look for changes. And then again, that's all of this comes together. So you can actually, after about 5 minutes, make your diagnosis. So this is the first case, okay? So this is an African-American female. She's in her 60s, and she's been suffering with hair loss at the vertex aspect of the scalp. And, she has symptoms. And, that's the one thing about hair loss is that sometimes there's no symptoms, even though it looks very aggressive and or diffuse or inflammatory, patients can have no symptoms at all. So this is a patient who presents with CCCA. So, and we know CCCA stands for central centrifugal cicatricial alopecia. So what I'll do is talk a little bit about CCCA, and then when we get to the treatment part, I want to talk to my colleagues and see exactly, exactly what they do as far as treating the patient. So let's talk a little bit about dermoscopy. I think it's very helpful. I probably do less biopsies now because of the dermatoscope or the trichoscopy, we call it. So in a patient with CCCA, you look for that white-gray halo. It's peripilar, and you see the hair exiting from the shaft. You also, when you think about the honeycomb network, that's really something that we see very commonly in skin of color patients. But the main thing is look for that peripilar white-gray halo that's at the base of the hair shaft. Okay, so treatment. We definitely have some experts here. Shoshana, how would you approach your patient as far as treatment for her CCCA?
So it's clearly inflamed. Now I actually use the compound metformin, topical metformin, a metformin with triamcinolone based off of Krista Agu's paper. And then I use that daily, but I have the patients use hyaluronide solution as needed, what I call, the hot spots, where when they do have symptoms, where they have it. And then I always give them an anti-inflammatory pill to stop the spread. Usually it's Doxy, 40 milligrams. But if the symptoms are severe, then I do go up to 100 BID. All of the patients are on an anti-seborrheic shampoo, and then a nutraceutical, a hair supplement. And I always give patients the option to whether or not to start minoxidil, because there's always a compliance issue. So the patients understand if you're not going to stick with it, we'll just take a L. Once the symptoms are under control, oh, I feel like you have all my answers right here. I'm reading your slide now.
And that's okay. That's
I was
good.
like, you were on point.
Yeah, that's fine.
Great audit.
And then the whole point is I tell the patients, put the fire out, right? Get the inflammation under control. For us, it's about a solid 6 months. And then we're moving on to something, either growth factors or exosomes or hair transplantation.
Great.
Cassandra, can you go into a little bit more about the metformin, the topical metformin, and what that's
Yes.
about? I know it's kind of new, and I just want everyone out there who's listening to Because it's important, big change, right?
Absolutely, absolutely. So to put it in perspective, we see about 200 CCCA patients a month, and we diagnose about 20 new ones a month. So I started using topical metformin in September, and that was after obviously reading Dr. Agu's paper, which I'll recommend everyone to read. One way to think about it simply is that it breaks the link between inflammation and scarring. That's how I explain it to patients. But what it's really doing is increasing the number of PPAR gamma receptors on the cells, because it's been found that the loss of those PPAR gamma receptors is what triggers the cell apoptosis and the scarring. So the same way that metformin increases PPAR gamma receptors, that will increase insulin going into the cell, those PPAR gamma receptors keeps the cells viable. And she was able to show that through the enzyme activity, et cetera. So the study though had the metformin in lipo cream, and I have a salon in my office. So I was able to tell right away, patients don't like it. It leaves a white residue, and it was leading to non-compliance. The patient didn't tell me they weren't compliant. The stylist told me the patient wasn't compliant. So I have a built-in truth serum in my office. And so I recommend you guys have it in an ointment, believe it or not. So we combine it with triamcinolone ointment. And we are seeing results. What we're seeing is what I was seeing new growth is excellent. Highly recommended. Just have your local compounding pharmacy use it, but you're still going to need, I believe, a separate higher potency corticosteroid because I don't want to put the metformin and a clobetasol chronically.
Yeah, and I agree with Shoshana, and we started using it too over the last 4 months. And so we're just now starting to really see our patients back. And I haven't decided on what's the best way to do it. So we have some patients who are on topical minoxidil, and they do that daily because we definitely think that that should be part of the regimen. And then they alternate in the evening with clobetasol, and we use 10% metformin, and we put it in petrolatum. And so they alternate that at night. And so in some patients, you know, we just do the metformin alone. So we kind of like have our own little study going on that we have different ways to approach it. And Crystal's paper, I have the reference right there at the bottom of the screen. And basically she had patients use it every other day, and another patient was every day. So I think you just have to find out kind of what works for you. And I do like the way Shoshana described, you know, the pathology as far as the mechanism of action. And the way I explain it to the patient is that when you do a biopsy, you see inflammation and you see fibrosis. So your doxycycline and your cortisones, either topically or injection, is going after the inflammation, and the metformin is going after the fibrosis. And so you're actually have two mechanisms of action going on at the same time to treat their CCCA. So that's kind of how I explain it to them. But let's move on, because I know I only supposed to have only 20 minutes, all right? So yeah, so this is, you know, the way Shoshana explained it, that's the way we approach the patients. So, you know, you can get some before and after good results like this with your CCCA patients. So, and it's so good to take photos. You have to take photos, because patients will say, you know, as you know, you see them in 2-3 months, and is it growing, you know, and you can't remember. So it's so nice to lift the patient's self-esteem when you show them the before and then you show them the after. Oh, they're just so excited, and they're the happiest patients on the planet. And that's what we're here to do. We're here to make our patients happy. And so this is a patient of mine who actually has CCCA and female pattern hair loss, or AGA. So you have to remember that the most common type of hair loss in all women is female pattern hair loss, or AGA, regardless of race. So then when you factor in the African descent component, the African gene, then you have CCCA. So these patients can have both. And so you always have to remember, and that's why topical minoxidil works, that's why PRP works, because a lot of these patients have both conditions at the same time. And so always remember that.
No, I always call this the shiny Christmas tree.
Mm-hmm.
Because it's like, you know, female pattern is the Christmas
Mhm.
tree. But when
Yeah.
you have that CCCA with it, it's like a little bit glistening, a little
Yeah.
shinier.
Yeah,
You
and
know,
then your
it's called the
dermatoscope.
shiny Christmas tree.
Yeah, your dermatoscope will tell you. You know, you'll see those gray halos, and then you'll see varying degrees of thickness of hair shafts. So you'll see vellus hairs, you'll see terminal hairs, and so you always, you don't really always have to biopsy, although biopsy is definitely the best diagnostic tool.
Did I hear Neil? Neil, were you saying something? Thought I heard Neil there.
Okay, let's move on. We'll catch you later, Neil. Again, so then with treatments, you have to tell the patient that there's active phase, and then there's regrowth phase, and then there's maintenance phase. So they need to know that this isn't just a one-time office visit. These are treatments that have a sessions that they have to do. It's a protocol that they have to follow, and they just have to do it. So again, the doxycycline, the shampoo, anti-seborrheic shampoo, the topical steroids, the injection of steroids, there's always a question on the dose, because I definitely have patients who come to the office with atrophy of their scalp. And so I can tell they were using 20 to 40 milligrams per cc injecting into the patient's scalp, okay? It's a big debit. So always remember to go about 2.5 or 5 milligrams per cc. Usually we see these patients every 4 to 6 weeks. I used to say ×3. Now I say ×5, and now I say ×8. So you just have to find what works well for you and your schedule. So then there's the regrowth phase. So after you get the information on the control, then it's time for your topical minoxidil. And now we're using a lot of oral minoxidil. That is part of the regrowth phase. And of course, platelet-rich plasma is the same. Patients always have to be on maintenance therapy. So I definitely keep them on a topical steroid, but it's definitely not the clobetasol. They need to come off of that because that can actually cause a lot of atrophy too, as well as depigmentation and hypopigmentation of the scalp. So cut it down, do something, give them something that's mid-potency, but still if they're having symptoms of itching, burning, then you may still have to do interlesional steroids on occasion. Okay, this is case 2. So this is a patient who presents with this localized circular area of hair breakage. And she tells you that, her scalp is itching, it's sore, it's tender. And the first thing you think about is, oh, she got hair color. She's having, acquired trichorexia nodosa, her hair's breaking off from that hair color. But when you biopsy these patients, especially when you see this complete round, demarcated circular area on the scalp, okay, you have to think about CCCA. Okay, so we published this paper several years ago where we took patients who had these circular areas of hair loss, and some had tenderness, some didn't, and we biopsied these patients. And so the pathology showed CCCA. So always remember when you see these, really round areas of hair loss or hair breakage, you got to think of CCCA, and that's when you need to do a biopsy. Shoshana, you see patients like this in your practice?
Absolutely. And thanks to you, I recognize it like that.
Yeah, it's something that, a lot of patients get misdiagnosed, but now
Unfortunately.
what we won't just misdiagnose. these
It's
patients
such an
anymore.
important article, Val.
Thank you. I
thank you.
appreciate it.
Thanks.
Yeah.
Mhm. Okay, so this is case number 3. So this is an African-American male patient who presents with this area circular right on top of his scalp. He's been seen by many dermatologists. All the dermatologists tell him he has AGA. This is male pattern hair loss. Okay, this is what they tell him.
Yeah.
Okay, but you know what? He has a little tenderness of his scalp. And he says, yeah, it itches in that area sometimes. Okay, what do you think, Neil? Shoshana?
Oh, CCCA.
Hey, all right.
Yes.
Okay, all right. always remember the differential diagnosis for central hair loss in males. It does not have to be androgenetic alopecia, especially if there's symptoms. And you can kind of look at the scalp and tell it doesn't look normal. It looks scarred. Sometimes it looks a little inflamed. So there have been reported cases of CCCA in men. So always keep that in mind.
Mhm. That's a great case.
Thank you. And this is a patient who presents with these patchy areas of scarring alopecia. She definitely complains of seborrheic dermatitis or dandruff of her scalp. Her scalp is always itchy, always
Mhm.
itchy. What do you think?
Not syphilis, must be CCCA.
All right, Neil, you hit it. I think this is important only because a lot of times when you see patchy types of scarring areas on the scalp, patients will give you a history of sometimes that they've had locks
Mhm.
and that the locks were very heavy. And when they cut off and remove the locks, because as we know, locks you can't undo. Once that hair has intertwined and is together, there's no way you can undo. You have to actually cut the dreadlocks off. And when they cut them off, they see these patchy areas. And so the first thing I used to always think about was traction alopecia. And because the locks are so heavy and they're pulling them up in beautiful styles, and I would say, oh, they got traction. And then, we started biopsying these patients, and then we look in the literature, and there's a new variant of CCCA, patchy. So always remember that the differential diagnosis may be, if they give you a history that they've had locks for 20 years and they cut them all off and all of a sudden they see these little areas of hair loss, but you may need to use your dermatoscope. And traction alopecia and CCCA look differently under the microscope, under the dermatoscope. So it's definitely important to keep CCCA again in your differential diagnosis of patchy hair loss. And definitely you also have to think about secondary syphilis, like Neil just stated, but you also have to think also about tinea capitis. There's been a case reported, well, there's several cases reported of adult females who take care of tinea capitis in their children having tinea capitis. And it usually presents with just either seborrheic dermatitis, that's what they're diagnosed of as, and it's just scaly. And there are, or they present with itchy, irritated scalp with hair loss. So you have a differential diagnosis there. Okay, so going to almost finish. Okay, so this is case 5. And this is a patient who presents with hair loss, and she tells you it involves the anterior hairline. And she just noticed that her hairline is just going back. And her scalp is a little sore. It's a little tender, especially when she goes to the hair salon and gets her hair done. And then she tells you, you know what, and my eyelashes, I'm losing them. My eyebrows I'm losing. They're getting very thin. And what do we know? Frontal fibrosing alopecia. So we do know that this is a condition that we're seeing more commonly in our patients. Originally, it was reported in Caucasian postmenopausal women, but now we know that it affects premenopausal women, it affects men, it affects all ethnic racial groups, Black, Asian. So we do know that it is a condition that affects all. Eyebrow loss is what we commonly see associated with this condition. We also see facial papules, sometimes around the temple. Sometimes I see a lot of facial papules around the chin area. And then, of course, one of the diagnostic tools that we use is the lonely hair sign. And that's where the scalp anteriorly is nice and smooth, and you see just one hair in the middle of this area of no hair. And we say, well, why did that hair escape the inflammatory process? We don't really know, but that's one of the signs of FFA. We know in the literature it's been associated with facial skincare products, with hair products, but there was a wonderful review by Dr. McMichael and others, and they said there is no evidence to state that it's a cause of CCCA, but it is still being debated. and this is how CCCA presents in women of color. And I always say it's almost like a white headband that you see. So there's hypopigmentation, which delineates the hyperpigmentation or the normal skin of the face. And you can see where the hairline used to be. And sometimes you'll see follicular hyperpigmented macules. And this just shows that in those areas, there was intense inflammation that destroyed those hair follicles in that area, and they left with PIH. You can have a psoriasis pattern. And I think this is very, very common in women of color. And of course, it's been diagnosed as traction alopecia forever. So it's probably occurring more frequently in women of color than we really know. But now we know that the psoriasis pattern can occur with alopecia areata. It can occur with traction alopecia as well as FFA.
So Val, question. On where you're getting the treatment. Oh,
Yeah.
it's a treatment question for this particular ophiasis pattern.
Okay. Well, I don't think I differentiate whether if it's ophiasis or just the anterior hairline. I think that the treatment is about the same. Are you saying that there may be a different treatment?
No,
for
no,
psoriasis?
the question is, and you have it here, is this a candidate for a hair transplantation?
I would say no. And I'm going to show you a paper why.
Okay,
I would say that it's a patient can maybe get micropigmentation,
Mhm.
but I definitely, because they do it for the eyebrows all the time.
mhm,
But I would be very careful, and I'll show you why.
Yeah.
So this was a paper that was published by Dr. Shapiro in the Blue Journal, and they just looked at what are some of the common medical treatments. So of course, we're using 5-alpha reductase inhibitors and definitely injections. And you see that most of his patients were on those two. Oral prednisone was rarely used, but other therapies include topical steroids, antibiotics, retinoids, and he has hair transplantation. We also, I think, doxycycline is still used in this condition. I think it's the best anti-inflammatory way to approach FFA or all the scarring alopecias, and then topical minoxidil, and now we're using more oral minoxidil.
Do you use hydroxychloroquine?
I used to, but now I go right to either finasteride or dutasteride, and I probably use dutasteride more now than hydroxychloroquine. And what about you, Neil?
I've used actually a combination of both dutasteride and finasteride together in some patients with frontal fibrosing alopecia. I've been disappointed with pioglitazone and its response in this setting. And I have transplanted a couple of patients with pretty good results. So I think, your experience may be somewhat different, but I think, in these people, we usually do a test session of about 50 follicular units. So I think that's something to consider. If it's inactive, there's no evidence of active disease. But the response to any of these treatments is very variable. And I do use also PRP in these patients in combination with the intralesional corticosteroids on an alternating basis.
Okay, now I have not used PRP with FFA. Okay, so that's a good pearl, everybody. Okay, all right, let's do it. All right. And so treatment intralesional, again, is what we use for these scarring inflammatory alopecias. And this was a paper that was published in the Blue Journal of looking at what was the correct dosage for dutasteride. And they looked at patients and they found that using 0.5 milligrams every day for 7 days, so every day of the week versus 3 times a week was more beneficial. So I used to do, because of the long half-life of dutasteride, I used to do it like every other day. But now I do it every day based on this paper.
Now, in your opinion, is this a 5-alpha reductase issue, why these anti-5-alpha reductase drugs work? Is it a form of lichen planus, as some people have said, and it's not so popular right now at this time? Or is it part of the spectrum of the central centrifugal alopecia and frontal fibrosing alopecia together as somewhat variants of a common inflammatory pathway leading to fibrosis?
Yeah, I think it's debatable, but I think the reason why I use the finasteride, because I still think there's a very strong hormonal basis for this condition and the effects of androgens. Even though we're seeing this condition in premenopausal women, the majority of women are postmenopausal. And I don't see this condition in men. I've never had a patient with men, even though it's been published in the literature. So I don't have an experience with men, but I will say that I think there is a hormonal aspect. There's androgens that are involved, and that's kind of why I use that. For the inflammation, yeah, I have these patients definitely on doxycycline as well. Okay, I know I'm over my time, so let me, I think this is, I just have a few more slides, so I'm just gonna run through these, okay,
Yeah.
Wendy?
You're,
Okay, so-
you're fine. There's some questions too, so we'll. move along.
Okay, so facial papules, I think is very interesting because we do see patients with FFA with the facial papules. And this is a great study that shows that isotretinoin, a low dose, is the treatment of choice. And this is the paper I was going to discuss where they looked at the literature and looked at all the different forms of scarring alopecia that are listed here. And there was success or growth in CCCA, Coupe de Sabre, DLE, pseudopelade, Brock, and folliculized decalvans. They had regrowth in these studies, whereas there was poor or no growth or definitely a recurrence of disease in LPP and FFA. And so that's why I said that. But Neil, if you're getting good results, then or it
I've
is
had-
worth a try for some patients. Some patients really need it.
I've had variable results with all of these conditions, but in selected cases, I've had reasonably good growth, but I always do a test session first.
Test session. I think that's so important. Absolutely. Okay, and then just to say for FFA and patients of African descent, if a patient presents with facial hyperpigmentation and they're concerned about it, it's very diffuse, you need to examine their hairline. And you'll find that facial hyperpigmentation isn't lupus, isn't a suntan, okay? Isn't a minocycline induced. It can be the result of FFA, and I find that more commonly than anything. And so this was reported by Dr. Delova from South Africa, and she reported many cases, and we're seeing it like there's no tomorrow. Most patients with FFA and skin of color have LPP pigmentosa, okay? Difficult to treat. Okay, last case, traction alopecia. I'm just going to go through it. Knowing the difference between the two, there's the fringe sign. So you see these vellus hairs. This is traction alopecia. Okay, so some of the follicles that remain are the vellus hair follicles. The terminal's been pulled out. Whereas in FFA, that lonely hair sign, as you can see in this depiction right here, it just knocks out everything in its path. Okay, it's taken out vellus, it's taken out terminal, the destruction is there. So this is how you tell the difference. One of the ways you tell the difference between
Now,
traction.
this is perfect because this was a comment in the question. So who asked this question and made this comment? This is like the perfect photo of the difference.
Yeah, and it's very, very helpful. You can use your dermatoscope also too. They look differently. And so this is one of the signs with dermoscopy, the flambeau sign, and you can see that little area there at the bottom of the hair shaft. And then you also have hair casts as well, okay? And this has been reported. And treatment, we talked already about a little bit about treatments, but and Wendy, you have a new treatment now for traction alopecia. So you got to do a case report. We got to put in the literature, Wendy, so we have it there. But right now, when you look at the literature, it's 2% topical minoxidil, it's intralesional triamcinolone. So we definitely do both. And you can actually see regrowth in patients. This is a patient of Dr. Amy McMichael's, okay? And this is using just intralesional steroids. So if you use the combination of the Rogaine plus the intralesional, you may get some results. And this is just saying that your dermoscopy is going to help you and you need to use it. You can see how AGA looks. You can see how scarring alopecia, that's a picture in the middle of lichen planus. I'm sorry, LPP, and then planopilaris, and then this is a CCCA patient.
Well, I think you need to do that talk next year. I mean, for GDerm, the dermoscopy with the disease. What do you think?
Oh yeah, it's so helpful. I carry it around with me, and I don't do as many biopsies as Dr. Kindred does. Dr.
I do
Kindred,
all by, I'm still
she
old school.
biopsies everyone.
Everybody.
She does, and I get a little busy, a little tired, so I whip out that
I
dermatoscope.
understand.
I need to get out. I need to get out on time. Okay.
I think it would be, yeah, I think this will be, this is what kind of, Val, that was amazing. And thank you so much. I want to bring up a few things that percolated up. One, CCCA is kind of the new great mimicker. We saw it mimic several different disorders. I think it's important for our audience to know that really the CCCA is epidemic proportions for African American women. So all of us need to, really have these tricks and tips and tools so we can go out there and identify these cases, which are often hidden under braids and wigs and weaves, and your lecture was really helpful in that. So don't discount CCCA out, put it in your differential. There was another thing that kind of has surfaced, is that a couple of times, and I agree, is watch your intralesional Kenalog. You really have to use small amounts to not cause injury to the follicle and the scalp. Another thing, the dermoscopy came out, use your dermatoscope and use it frequently. There's a question about doxycycline that came up. How long do you use it for? I use doxycycline. Well, let's go back. First of all, don't forget about the earliest signs of CCCA, which Val, you mentioned several times. Itching, pruritus, stinging, burning, tenderness is not always seborrhea, but CCCA. I use doxycycline until those symptoms are resolved. When a person doesn't have stinging, itching, burning, or pain, then I stop. It's usually not longer than 3 months. Usually I find it about 8 weeks, but if they still have any kind of symptoms, then I will use the doxycycline. I hit it a little bit harder. I do 100 a day, and I do it until symptoms are gone. So do you guys want to go around and talk about your doxycycline? Because that was a question.
Yeah, I usually do 100 BID times 3 months. I got that from Lynn Sperling. And so I've always done 3 months, and then I titrate down. I think they need to still be on it. So I may go to 100 or I may just do 50. So I like them to be on the higher dose for the first 3 months, and then I titrate them down. So they may be on it a little longer, maybe 6 months.
Right. I figure it doesn't hurt, and inflammation's so huge. There was one thing that wasn't talked about, but again, I want to talk about, just throw in that toolbox again, the topical carboxy therapy, because especially in the inflammation portion, I do use that. It really cools everything off, brings in circulation, which circulation is also not only bringing oxygen, but also removing inflammation. So I want to put that in. My recipe for CCCA is topical scalp carboxy therapy. I think it's great at the beginning. Now, another question came up. I think it was 10% the metformin in triamcinolone. And it was for the question audience, it was not the cream, because they said that was not compatible with African-American hair. It was in the ointment. So not triamcinolone cream, but triamcinolone ointment.
Or you can put it just in petrolatum.
Petrolatum. Great. Okay, I think that's it for the questions. Thank you.
You're welcome.
That was great, Dr. Callahan.
That was
One other
great.
comment.
Great discussion,
One last
guys.
comment. We also use in our practice now the Caravive or the Quo, also low GLO, to try to cleanse the hair follicles and decrease inflammation as well. So that's something we've incorporated into our scoring alopecia armamentarium. So for scalp health, and we're doing some studies now with the University of Minnesota looking to see if it affects inflammation in these disorders.
Great. Thank
What
you,
percentage
Neil.
are triamcinolone?
I use-
0.1 or 0.025?
I use 0.1.
Thank you.
Okay, we'll take the next slide. I'm going to introduce our next speaker. I'm so excited when she said she was okay, this is the final exam for later. Okay, we can skip over these. So excited about her joining us this evening. Dr. Chisana Kendrick Weaver is an MBA as well, FAAD. She's board certified dermatologist. She practices in Columbia, Maryland, and recently named Physician of the Year by Maryland's Daily Record. She's the founder of Kindred Hair and Skin Center, chair of the dermatology section at the National Medical Association, and congratulations on having a great meeting that you just wrapped not long ago.
Thank you.
Associate professor at Howard University and the founder and president of the Onyx Medical Society. Dr. Kindred specializes in alopecia and is the first dermatologist in the nation to have an in-house full-service hair salon and nail salon for her practice. So I asked her today to speak to us about that important relationship of the hairdresser, the hairstylist, to the dermatologist, and just your thoughts in general about it all. Welcome to GDerm Fresh, Dr.
Thank
Kendrick.
you. Thank you so much for inviting me. I feel really honored to be along this panel, particularly with my mentor, Dr. Callender. So as she mentioned, I'm going to cover the role of hairstylists and a little bit on products, but you'll see soon why I won't harp too much on products. So firstly, I have some financial disclosures, but they're not relevant. And I can always share that again for the sake of time. I'm going to give two very specific examples on how the relationship between stylists and dermatologists is so important for the improvement of our patient alopecia outcome, and then also some intangible benefits, and then cover products. So first case, for this case, Dr. Callender touched upon it, and I guess, we're seeing kind of the same population. Anytime you see this, automatically, you should think a patient had locks and cut their hair off. I'm seeing that a lot more. All of my RPRs are coming out negative. So her loctician sent her to me because they were suspicious of traction alopecia. And her loctician was being very careful not to tighten too much. So the role of the hairstylist, loctician, braid, or whatever, is that they were encouraged healthy hairstyles and kind of recognize before you ever see the patient when it's time to switch from a hairstyle that might be detrimental. And they also train the patients on how to take care of the hair in between the stylist visits, in between your appointment, etc. And then more importantly, is the stylist certainly reinforce your advice, because you know that we're going up against Dr. Google. The next, just to close this loop, so that patient, we were able to bring her traction back, but as Dr. Callender says, I biopsy everybody, and it actually turned out she had CCCA. So we think what was happening is she had a great loctician who wasn't tightening too tight, but they were still seeing worsening. Particularly, we look at the parts, and it turned out that while she had traction, the biopsy also showed CCCA in this case, and now we're treating the patient for her CCCA. So speaking of CCCA, the stylist in my office, Susan Peterkin, she has a campaign amongst her colleagues called Check Your Center Part. So she's teaching stylists, part the hair down the center and then pay attention. And we know to look for this, right? Particularly after the CCCA scale that Dr. Callender and Dr. Lisa Olson published. She's training them to look for the widening of the part. And while we've coined the term, Dr. Callender coined the term CCCA, stylists have known about this for decades, and they refer to it as a sweet spot or a soft spot because they know to be careful around the vertex because the patient's scalp is tender or inflamed Or as Dr. Callan just pointed out, they have CCCA form for us. Stylists already know about it. They just don't know the medical term. And we have to partner with them because those are our triage nurses, honestly. And then just to close this loop, we treated this patient standard. I think she got, to not use brand names, like a deep cleansing where we suction out the gunk out of the follicle and then squirt in growth factors. The important thing is once you get the patient better, that is now going to be one of your most non-compliant patients because you caught them early, you reversed it, and they think they're good. The stylist helped to maintain them on their treatment regimen. The other way that stylists are helpful, and it's not something you can measure, but we need them to be the partners on these myths. They can either promote a myth like biotin and apple cider vinegar and all this other stuff, or help dispel it for us. So if we give them the facts, they'll make a lot more headway than we ever will, because for every stylist that we train, we're probably helping close to 1,000 patients. How many of us want rice water to die? So this is a great case. So this is a patient that's CCCA at baseline, and about 4 months in, and this is where she was. Now, yes, she had everything. She had oral minoxidil and nutraceuticals and an antiseborrheic shampoo, and metformin wasn't out at this time, and intralesional Kenalog, antibiotics. She had everything, and she turned around. Now, in our community, our medical community, we all would be patting our backs to get these results this fast. But as you can see, she still has this zone of hair loss. So she would still be wearing a wig despite what we accomplished. And you can see a battleground between a little bit of stubborn traction alopecia, and there's a fringe sign Dr. Callender pointed out, from continuing to wear her wig. Well, she sees a stylist in my salon, and the way it goes is the patient walks in and sees the stylist first, gets her hair washed, conditioned. Our stylist does an herbal rinse. If your hair is brittle, she'll do a steam treatment, blow dry. The patient goes across to the exam room, and I do my intralesional Kenalog or PRP or whatever. Then the patient walks back into the salon, and that's where this patient is at this stage. Well, the stylist proposed that you don't need to wear a wig. Let me try styling you. And this is the style that the stylist did. And it perfectly covers up that patch of alopecia that would make this patient want to wear her wig. So the stylist, not me, got her out of the wig sooner. I would have needed another 3, 4, 5, 6 months before I could have gotten the patient out of the wig. And if you notice in these photos that she's wearing the same shirt, and that's because it's the same day. And she walked out of there and she hasn't worn a wig since. So the stylist can be very beneficial for what we do for our practices, but what they don't do is diagnose, treat, and prescribe. And so that's what I want you guys to watch out for when you look for stylists in the community to partner with. There are some that want to be the doctor. Stay clear away from them. They're the ones who wear white coats. They call themselves Dr. So-and-so. They say that they can diagnose and treat, and they have all the fancy devices, and they charge $300, $400, $500, and they don't triage and send patients to the dermatologist until well after it's way too late. And then you're stuck with a stage 5 when you could have had them at a stage 2 or 3. So you do kind of have to screen which stylist you want to partner with, because it can certainly backfire. So in regards to products, a lot of times people will ask us, what products do you recommend? Implying that there might be one product that works for her and her and her and her and her. And there is not a product that exists, a single product that'll make all of these ladies happy, let alone, it depends on which hairstyle you wear. So when I wear my hair like this, I use one set of products. And when I wear my hair like this, I wear a different set of products. So I think the role of the dermatologist is to know the ingredients, which ingredients to use, which to avoid, which are carcinogenic, which ones are not, etc. Because to get down to the patient satisfaction part and the health of the hair, we need the stylist, it needs to be coupled with the stylist experience. So dermatologists have the best of intentions in recommending a product based on the ingredients. And the stylist will tell me right away, no, that's gonna not feel good. Her hair is not gonna curl right. It's gonna make her hair frizzy, so on and so forth. And then finally is the patient's opinion when it comes to product. All of that comes into account, or should, before we recommend a specific product or put our name behind a specific product. But to cover products a little bit, if we look at shampoos, the term sulfate free is a gimmick because it has sulfates in it anyway. That's a marketing ploy. But when you do look at the ingredients, you want to avoid SLS, and you do want, it's okay if it's a laureth sulfate, but we kind of know that based on just our training anyway. And in regards to ketoconazole, we typically avoid ketoconazole. We sell a 2% zinc pyrithione shampoo, but for patients that, for whatever reason, with curly hair, particularly Afro texture hair, who needs a ketoconazole shampoo, or we have to prescribe it, is definitely coupled with the moisturizing shampoo before and after, followed by a deep conditioner, and I'll cover conditioners in a hot second. And the ketoconazole shampoo shouldn't be ran throughout the whole strand. It really just needs to be focused on the scalp. Another trick is that you just have the patient part her hair or his hair and apply it to the scalp and then wash like normal. It's because it's heavily sulfated and it really strips the hair strand. And then frequency. For curly hair, the sebum doesn't slide down the hair as easily as it does with straight hair. So the hair doesn't get as greasy or oily or attract as much dirt. In fact, we put oils in our hair because it's actually more prone to get dry. So we still have colleagues who are telling patients with Afro texture hair, with really curly hair, with really long hair, with color dyed hair, to wash their hair with ketoconazole shampoo twice a week. And that's not a good fit. It should be every 1 to 2 weeks, or just avoid ketoconazole at all. Those are just my recommendations, kind of how we were trained at Howard. So in regards to conditioners, there's a bunch of different types. And it's a matter if you want to go down that rabbit hole or not. There's leave-in conditioners, there's deep conditioners, there's rinse out conditioners, there's light daily conditioners, there's protein conditioners, so on and so forth. But basically what we want to know, it balances out the charge of the shampoo. So for every person of Afro texture hair, for sure they need a conditioner. One is cationic and the other is anionic, so they balance each other out. The conditioners also helps the hair to be more manageable, gives it a bit more of a slit. And with that slip, it's less likely for the hairs to become a knot. And if you look at hair, say of my texture under a microscope, if it's left alone a little bit, you'll literally see a knot as if somebody sat there and tied my hair like a shoestring. And the conditioner helps to be it more manageable. And then especially protein conditioners, they literally strengthen the hair strand. And if you'll see little holes in the cortex of the hair, and it'll just kind of plug in those holes. So just in summary, the stylist, that's the person that's going to help you with prevention, because they're going to help promote and train the patient on healthy hairstyles. They see hair loss before we do. If a patient comes in because the patient recognized the hair loss, that was too late, the stylist can see it first, particularly if they're checking for any widening of the center part, and they can get that patient to you in an earlier stage in a disease process. The stylist also helps the patient to stick with their regimen. They'll also help to promote facts, which is, if no other reason, that's one of the best reasons to partner with stylists. And then the stylist, she stays in her lane. She does, cosmetology for hair, not treatment, diagnoses, or prescriptions. And I stay in my lane. Every time a patient comes in and asks, oh, well, which products do you think? I say, hey, stop right there. I run and grab the stylist, and the stylist comes in and talks about products for that patient. Okay, so I think I tried to stay within the time because I know we're running just a little bit late, but if there's any questions, I'm happy to answer them.
Thank you. Thank you, Tasana. That was wonderful. And we'll do some questions at the end too, for those of you who want to hold on. Okay, our next speaker. Take our next slide. Dr. Sophia Kogan is the co-founder and chief medical advisor of Nutrafol. Dr. Kogan earned her medical degree from SUNY Downstate. She did residency training at Tufts New England Medical Center and SUNY Downstate Medical Center. She completed a research fellowship in pediatric dermatology. In search of answers to her own health and hair thinning issues during the stress of medical school and residency, in 2015, she partnered with Georgios Testis and Roland Peralta to co-found Nutrafol, the first clinically effective hair wellness supplement to use medical grade bio-optimized ingredients that target multiple root causes of hair thinning. Sophia, we're so happy to have you today. Welcome to GDerm Fresh, Dr. Kogan.
Thank you so much. I'm really happy to be here today. And I'm in such great company. I don't know if I can follow Dr. Calendar and Dr. Kindred, but I'm going to do my best. So I am, hold on one second. I have to share my screen. Great. So can you all see what I'm seeing? Is great. Okay, so I'm going to be talking to you about a topic that I think is near and dear to all of us today, and it is today's stress and how it affects our hair health and nutritional interventions for stressful times. And so can we all agree that 2020 was a very stressful and seriously stressful year, and 2021 is turning out to be pretty stressful as well. Now, in 2020, American Academy Psychological Association, which yearly surveys Americans about stress, issued a special report that year that basically determined that it was a national mental health crisis that could yield serious health and social consequences for years to come. And that was the first time there was an increased amount of stress since they started the survey in 2007. So as we know, many people were stressed not only about the coronavirus, which was around 78%, but as well as children, parents were very stressed out. And then what's really what we're seeing now is this, there was an acute period of stress, but now we're seeing this chronicity of things are not going away. And of course, there's the economic challenges that are coming forth with job security issues, as well as police brutality and race relations. So a lot of these things that have been contributing to this particular 2 years of extraordinary stress. So it's not we're not surprised at all that we started seeing a lot more stress-related thinning. And of course, the quintessential one is telogen effluvium. And what we initially started seeing in our company is actually, our doctors coming forth and talking to us about seeing more patients in their clinics with excessive shedding coming forth, as well as customers reaching out to us to tell us that they're experiencing more shedding in general. And what we understand now is there's the people who had COVID also experiencing T, which of course the pathophysiology still remains to be fully elucidated, but at least in part is due to the physical stress of a febrile illness. And there's more people who are stressed about it. And I think it kind of comes in waves. We're sort of like dampened down at this point, but of course with this Delta variant, again, everybody is stressing about how to protect their elders, how to protect their children, how to protect immunocompromised people and themselves and their families. So it seems to be a non-wavering sort of constant sort of chronicity of this stress that's coming forth our way. And we started to see published reports as well, demonstrating that there was an increase in telogen effluvium, as well as other skin pathologies that can be triggered and made worse by stress, such as alopecia areata, androgenetic alopecia, psoriasis, atopic dermatitis. So a lot of different things. And how does stress impact our our systems? How does it affect us? And so there's twofold effect, and there's the systemic impact, which happens, it kind of actually touches every single one of our systems, as well as a local impact on the follicle. And when we think about such a quintessential stress-related thinning, we think of telogen effluvium, which basically is a shift, right? We know that normally there's a biological clock that ticks at its own pace. It happens regularly for all of our hairs. And luckily for us, we don't, it's unsynchronized. So meaning that we don't shed like rabbits all of a sudden and then grow new fur. It is, it happens staggered. But when there's extra stress on board, and there are multiple factors that of course are going to impact this hair growth cycle, but stress particularly will shift it from a lot of the follicles into the catagen phase, which further shifts it into the telogen, after which the hairs are released. But what's also really interesting is that cortisol hormones and will also actually delay recovery, as in delay the process of you coming back to anagen as well. And at the follicle, this looks like this. It's a diagram that shows basically the follicle, interestingly enough, has cortisol and corticotropin releasing hormone receptors on it, and actually a fully functional machinery to produce its own hormones. And when I think about it, is that the skin is like it's like an antenna in the skin. It kind of modulates this skin responses to stress. And what happens when there's an elevation of cortisol hormone locally, or corticotropin releasing hormone, is that there's a degranulation of local mast cells and inflammatory pathology, as well as hair growth inhibition and apoptosis. And of course, there's a contribution from the local nerves with production of substance P and other factors that can impact the immune privilege of the follicle. So there's a lot of neuroimmunoendocrine factors that are directly impacting the follicle at the level of the follicle, as well as the systemic shifts that are happening during stress. So what can we do as practitioners? And I know that there's absolutely no pharmaceutical agents that can be specifically prescribed for stress. We can't give a patient a pill for stress. We don't have medications for that. We do have medications for symptoms of stress like anxiety and depression, but not for stress directly. And we certainly can't prescribe them avocation to grease. What we do have are these natural adaptogens that are kind of amazing miracles of nature. And it's a class of natural substances derived from plants and mushrooms that actually increase the organism's ability to adapt to stress and build resilience to it. And I want to try to use today's terminology to make it as simple as possible without going into too much detail, because they really impact multiple receptors. But what's really important is that when we think of this curve, right? So the stress response goes up and it comes down, high and low. And what we do and this is the homeostasis line, but with an adaptogen on board, we can actually flatten that curve of the response and create an easier or a more moderate response to stress, which of course impacts us physiologically and also mentally. And one of these incredible adaptogens is called ashwagandha, and the one that we particularly use in Nutrafol is called sensoril ashwagandha. It's standardized to 10% with phenolides, which is the highest available amount, and it is patented water extraction method technology, which preserves the bioactivity of the actual of the bioactives in it. And what's really incredible is that it has over 12 clinical studies and counting. So it's been completely clinically studied for efficacy and has been shown to reduce elevated cortisol levels in chronically stressed adults, and also improve feelings of stress, as well as improve people's mood. So the so the thing is that stress is only a singular trigger. Although it is a major trigger, there are multiple other triggers that play a role in hair thinning, and hence multiple factors are involved. So when we think of what we have, in totality, we have stress, we have
Factors
genetics,
or
we have.
something like that, I forgot one.
Can
Sorry.
everyone mute, please?
All right, DHT hormones are involved: free radicals, aging, styling, UV toxins, environmental contribution, inflammation, oxidative damage, compromised circulation, and of course, compromised nutrition. What we have available without the contribution of botanicals is we have ability to target DHT hormones, and also I would say not just nutraceuticals, but also multi-targeted therapies such as PRP and other therapies that are coming out that can target multiple factors at the same time. But also we have the ability to affect compromised circulation that Dr. Roberts was talking about, as well as fill the nutritional gaps in some capacity. However, when we use standardized botanical nutraceuticals, they're actually able to, by their very nature of having ability to target multiple receptors, they're able to target many factors at the same time, stress being one of them. So this is what it looks like at the follicle itself, and how these botanicals work. And we currently have several multi-targeted clinically tested formulations on for you that address multiple factors. What I want to say is that each one of these formulations has been clinically studied and has been formulated with this particular stress adaptogen called ashwagandha, and has been formulated for according to biological gender and age and age. So the women's and men's formulation has nutraceutical synergism complex, which I already spoke a little bit about ashwagandha, but also contains curcumin, which is an incredible immune modulator, saw palmetto, which is a clinically proven and recognized potent natural DHT inhibitor. There is an increased amount in the men's formulation due to men having high levels of testosterone and DHT and being more sensitive to it, as well as the tocotrienol tocopherol complex, which targets oxidative damage and has been shown to increase hair growth on its own, and it's also fortified with many other ingredients. And with the I think it's good to know what it looks like, as a hypothetical scenario of how these ingredients work in the body. However, it's always important to have clinical studies behind what we do. And so this is a 6-month randomized double-blind placebo-controlled study on women with thinning hair, and 40 subjects were involved. We basically saw an improvement in objective measures as well as subjective measures, including improvement in terminal and vellus hair counts, as well as blinded physician assessments and self-assessments as well. And you can see some of the before and after pictures. So I want to touch a little bit about on the mechanisms behind how the menopausal transition happens and the contribution of stress here. So not only do we see, so what happens immediately at the menopausal transition is that estrogen and progesterone drop pretty rapidly due to ovarian decline, and testosterone lingers. So what we have in the hormonal sense is sort of like a relative testosterone dominance. And in addition to that, however, during this period of time, women also experience increased stress and increased cortisol levels as well. And what we did was we wanted to make sure that these particular specific needs are addressed with the formulation. And so the Synergen Plus complex contains also maca, which is another adaptogen. And it not only has an adaptogenic ability against cortisol, but also has adaptogenic ability to help sort of mitigate these shifts and changes in the hormones that are happening during this time. And maca in itself has been actually shown to improve secondary symptoms of menopause, such as hot flashes, night sweats, and sleep and mood and headaches. We also added extra astaxanthin, which is a very potent antioxidant, which we do see an increase in oxidative stress with age. So it was important for us to add this to this formulation, as well as increase the amount of saponiferol for that extra testosterone dominance, which the extra DHT component that happens specifically in women going through the menopausal transition. And I'm very proud of this particular study because it is the only one done on with a supplement on women going through menopause. And we included women who are perimenopausal, menopausal, and postmenopausal. And this is our 6-month result. We saw an improvement in terminal and vellus hairs, objectively, and vellus hair counts and terminal hair counts, as well as total hair counts. We also saw a decrease in shedding of 32%. And we also saw an improvement in, self-reported outcomes and, of course, physician assessments as well. Now, what's really great, and I'm not showing it here, is that we just finished our 12-month study with the extension of the study, which is a 12-month period of time. And we are actually seeing great results, which will be published very shortly, and further improvements, so to speak. So it's kind of exciting for us. Now, when I want to go back to the stress thing, right? So in response to the extra stress that's been happening, what we really want, we kind of anticipated that, they asked there's going to be more telogen effluent stress-related hair loss. We wanted to make sure that we give you extra support for your patients in terms of stress. So we have this Stress MD booster and adaptogenic booster, which actually, what I really love about it is that it is professional strength. It's only distributed through doctors, and it has 4 adaptogens that are holistically supporting the HPA axis and its feedback loop. So there's the upstream components, midstream, and downstream. And what's really incredible is that ashwagandha actually shows a dose-dependent decrease in cortisol and stress-relieving benefits. So with the addition of this booster, you can see further results in terms of helping patients with their extra stress component as well. And of course, stress adaptogens also support the immune system that is triggered by stress, so they help regulate that as well. When we think of stress, we also think of gut, because that's our second brain. And the more we learn about it, the more we understand. And I think we're just at the very, very tip of the iceberg as to what is happening with the microbiome and how it impacts us, how it impacts hair, how it impacts skin, all of it, And so what we understand is that when we have a disrupted or dysbiotic gut, we see increased permeability, which further causes systemic increase in low-grade inflammation, and as well as poor nutrient assimilation, which can certainly impact hair directly. And what we wanted to do was really find a way to support the gut as it relates to hair. So to diversify the gut microbiome and help improve gut lining, as well as nutrient absorption, and support a healthy immune response as a result, and really strengthen that gut hair axis. So we created a professional strength hair biotic MD booster formulation, which is formulated with 25 billion CFUs of 10 probiotic strains of 3 different types and an innovative bacteriophage prebiotic, which is really cool. I just wanted to, I'm trying to run through it a little bit quicker because I know we're running behind. So I want to show you some of the before and afters that we have. This is from the women's formulation. Again, this is a 3-month result. Actually, this is a dermatologist and she was very stressed and she was reporting that to us. This is from our women's balance study. This is one of the patients. This is a 6-month result, so pretty impressive. This is our 6-month result, again, women's balance. So that was a, I think, postmenopausal woman. Sorry, I'm going backwards. Postmenopausal woman, menopause, and this is a menopausal woman. after 6 months. And again, another patient from that particular study with who is in menopause and saw results in 6 months. This is a man from a men's study, and this is a 6-month result as well as a young 22-year-old guy on men's for 3 months. I wanted to show you a little bit of before and afters that we together with stress adaptogen boosters. So these are patients that were specifically reported extra stress, and that's why they were given the combination. Again, this is for patients who are either shedding more or reporting stress, or both of those. I think all of those types of patients that are coming into your office that you could recommend this to as a pack in itself. And likewise, a woman who was extraordinarily stressed, also recommended to take both of them. I think she took core exclusively quarter for 4 months, and then they added a stress adaptogen booster for her. Very quickly, I want to share with you some news. And part of that is that we just came out with a postpartum formulation that, and as postpartum hair thinning, there's a huge contribution of stress during that time. So again, I think it kind of completed our cycle of women's, specifically products for women, because we want to really support that woman through every stage of her life. As women, we tend to have specific stages during which hair shedding and thinning is seen more so. And one of those stages is postpartum, another one is menopause. So pretty proud of this product. And just to touch a little bit upon what happens during this time is that estrogen and progesterone, so the hormones that are supporting the baby and the pregnancy, are elevated by 800 to 900% during pregnancy. That kind of supports these trophic hormones are actually supporting the follicle to stay longer in anagen. So we call prolonged anagen, and then delayed release of anagen afterwards. And so when they drop after, suddenly drop during after birth, at the same time, there's an increase in cortisol by 200%, something that we don't often talk about it, but that's actually happens normal, and likely for the reasons that, you kind of need to be superhuman afterwards to take care of the baby. So that really impacts the hair follicle directly through these changes and shifts in hormones. And although we can't really do anything about these hormonal shifts that are absolutely normal and natural to have, and as we know, according to the American Society of Obstetrics and Gynecology, most women will experience postpartum shedding and thinning. So it happens as a normal process. However, there are other contributing factors that we understand are happening at the same time. And those are the physical stress of childbirth that we don't normally think about. There's a healing process afterwards that happens that the body needs to go through. And that, of course, involves the immune response, the oxidative stress as well as the emotional stress, right? So there is that elevation of cortisol and sustained cortisol levels afterwards with the new baby and becoming a new mom. And as well as what's really interesting is that there's a postnatal gap, nutritional gap that happens. So we have prenatal needs and postnatal needs, but most of the time women are told to take prenatals postnatally, and that really doesn't cover that nutritional gap that is occurring during that time. So we created this product with an OBGYN, and it contains only breastfeeding friendly nutraceuticals, and it's really created to specifically target these root causes that are additional and that contribute to shedding and to support healthier hair growth during this transition. Some of the ingredients that are included in the Synergen Recovery Complex are the apple extract, which is specifically has been shown to improve, specifically for hair. My favorite one is Shatavari, which is actually a stress adaptogen that is recommended or actually taken in some cultures during this period of time for recovery of women postnatally. And it happens to also, again, support the reproductive health, as well as known to support and to support this stress response. Theanine also targets stress. Algae and omega-3s support the immune response and oxidative components during oxidative stress during this time. We also included some ingredients such as collagen, stabilized orthoxylic acid, which has been shown to promote stronger hair growth, and other ingredients as well. Nutrafol Postpartum Hair Blend contains other specific ingredients for hair, such as pea sprout and sea buckthorn, as well as last but not least, again, I talked a little bit about this postnatal nutritional gap that happens, that is not commonly filled with prenatals. And what we did was we made sure that we created this product that would fit and would be able to be taken with postnatal and prenatal supplements and other multivitamins. So a woman doesn't have to choose between this and her prenatal. We're not looking to substitute that. So thank you so much. And if you have any questions, let me know. Again, such an honor to be here and amongst the most incredible hair specialists that I know.
The video.
Thank you so much. Thank you, Dr. Kogan. That was great, great information. And just if you can stay on, we may have some questions after, but we're going to move along now with Dr. Sadik. Dr. Neil Sadik is a native New Yorker, completed his medical school training at SUNY Upstate in 1977. He has trained in dermatology at New York Hospital and holds 5 board certifications in internal medicine, dermatology, cosmetic surgery, hair restoration surgery, and phlebology. I think that says about it all and certainly describes the man. Just a great person and very generous. Neil, thank you for joining us tonight on GDerm Fresh. We can't wait to hear what you have to tell us.
Thank you so much, Wendy. And it's a great honor to be here with some of my esteemed friends and to listen to all of the new approaches that we have of bringing the field of hair disorders and prevention of hair loss forward. So it's a great honor to be part of this faculty. We can go to the next slide.
Dr. Sadik, can you turn your video on?
Yes, I can do that now. Okay. Okay. Yep. Okay.
Oops.
I got it. Okay. So the first part of my lecture is going to talk about what's new in treatments for hair loss. If we see the next slide.
Yep, and your video is still not on for some reason.
The video is, okay. Let's see. Is it on now? I don't know it.
But we can see your slides, Neil.
Yeah, it says, it's not starting the video. It says unable to start video. I'm not quite sure why. But hold on one second. Let's see. It says the host has stopped it.
We can't turn it on for you. Can you, where it says bottom left corner of your screen, start video?
No, I know that, but yeah, it's not starting. Can unmute.
No, the host will start my video. Click here.
Okay, let's see here. There we go. I think we're set now, right?
Yeah, we see you.
Yes, we're good now.
Okay, perfect. We can go to the next slide, okay? So the theme of this talk is hair loss, and I think there really is a pandemic around the world now in terms of hair loss being recognized, and really one of the major problems that all physicians, particularly dermatologists, are seeing in their office. Next. And it's being made worse by the COVID pandemic, where we're seeing so many hair cycling issues such as telogen effluvium. As you can see here, that the size of the problem is really tremendous here. And more and more individuals are coming to our practices looking for both medical and surgical, again, intervention to slow down their hair loss and also to regrow their hair. Next. So, when I was still a resident at Cornell, we developed Propecia, 5-alpha reductase inhibitor, and I feel that the role and the etiology of hair loss in men is much better understood. In women, I still think we really don't have a good understanding of the cause of hair loss. I personally believe from our research, our biopsy studies, that inflammation plays a more major role in women in terms of common hair loss. Next. So here again are some of the multifactorial pathophysiologic mechanisms that may be associated with hair loss. And I think that genetics and inflammation, and Sophie talked about stress, and certainly we're seeing more of that, which has led to a significant number of patients presenting to our office with telogen effluvium and anagen effluvium, basically cyclically disorderly progression of the hair cycle follicle cycle. Next. So with our patients with hair loss, I won't get into this for time, but it's really important to do an excellent medical evaluation. I find that the most common secondary causes of hair loss in my patient population actually are medications. So many of particularly female patients are on antidepressant medications now. I also see a lot of iron deficiency anemia. Those are probably the two major secondary causes of hair loss that I see in my practice, other than common genetic hair loss. Next. So we talked about physical examination. I won't spend too much time on that. Next. Blood work, I think, is really important. I'm particularly looking at vitamin D levels now and iron stores, in addition to hormones, as being secondary factors that one may be able to reverse and may be playing a secondary role in hair loss. Next. These are some of the diagnostic tests, but the major test we're using that hasn't been mentioned yet is what's called the metrics, which we helped develop with Canfield, and we'll come to that in a few moments. It's an artificial intelligence type of technology. Next. And this is this artificial intelligence type of technology, and it sort of is a form of epiluminorescence microscopy, but you don't need to clip off the hair, you don't need to tattoo, and it gives us extremely precise images that you can see on the left on the bottom. And you can see from the graphs also, it tells us the number of germinative hairs that are stem cell type hairs that can be resuscitated or stimulated. And then in the yellow, it shows, again, small anagen fiber hairs with diameter, and then the green, more normal, healthy hairs. So for the first time, we're now able to do excellent imaging, but more importantly, we're able to quantitatively follow our patients with any of the studies that we do, or just our patients in our clinic as well. For example, if patients are doing PRP or other treatments that are costly, we're now able to give them actual, again, quantitative information as how effective these treatments are. Next. The hair loss options we've talked about. Let me just talk about some of the newer ones that we've not discussed yet. Next. Next. Topical finasteride is something that our research group has been studying as well, and you can see there are positive results in phase 2 trials. And I actually, for some of my patients, use a combination of topical finasteride and topical minoxidil, particularly in those individuals that are not responsive to topical minoxidil by itself. Next. And as we've talked about before, more and more of my patients, probably about 70 or 80% now, instead of using topical minoxidil preparations, which we use up to 9%, are now being switched to oral minoxidil. We usually start with a low dose of 1.5 milligrams and then progress patients up to 2.5 milligrams. Also, I biopsy all of my female patients with hair loss, and we're able to segregate two groups: common female pattern hair loss without inflammation, or common female pattern hair loss with inflammation. If there's inflammation, lymphocytic inflammation on the biopsy, and all these patients also have IgM immunoreactivity, if I'm going to use a topical agent, I mix the minoxidil with a medium potency topical steroid that I use on the scalp, and then rebiopsy the patient 6 months later to see and look again at our computer analysis to see whether there's increased hair growth and whether the inflammation has resolved. Next. But I think that's going to be an increasing trend. This is something that's particularly new, and this is an enzyme booster that can be added to minoxidil that has been shown to, again, improve in a clinical study hair regrowth with minoxidil type preparations. Next. PRP, I'll just touch on that. Next. I work with Maria Herdinsky and Rhonda Farah in a hair research center at the University of Minnesota. This is a new book that came out on PRP of all the studies and our clinical experience and the clinical experience of people around the world. And the other is a dermatology clinic. If you want to read more in detail about practices and the theory behind PRP, I'd recommend looking at one of these two books. Next. But the basics of PRP, I won't get into in any great detail. Again, we isolate our platelets, platelet poor, platelet rich plasma. We only use platelet rich plasma. And again, it's usually 7 times the number of platelets that you see in normal blood. And again, these are felt to have an increase, again, vasostimulatory effect. And I think the major effect of PRP actually is on reduction of inflammation and programmed cell death or apoptosis. And we now have studies that we're working on to look to see what the mechanism of action of PRP really is. Next. This is also a trial that we're now looking at with a new generation of PRP that combines PRP plus hyaluronic acid together. And the hyaluronic acid is felt to stabilize the growth factors so that they remain, again, in the target area where it's injected for up to several days rather than several hours, of which PRP has shown to do that. So these studies are now ongoing with our research group and that of Maria Herdinsky and Rhonda Farrett. Next. Here's the injection technique. The one thing that I found, I was using nitrous oxide for pain relief for a while. I was using vibratory devices, squeezy balls, but I found that the Zimmer cooler is actually the best, again, non-invasive type of way to reduce, again, discomfort with PRP. We usually do 3 injection sessions next. And then we sort of separate, moving from once a month for 3 months and then to every other month. Then we usually do, again, a metrics evaluation. If there's some improvement after a 3-month interval, we move into, again, 4 times a year, every 3-month type of injections. Here in this one study, I'll tell you 2 conflicting studies. It showed that in patients, when they looked at various PRP preparations, the preparations that had the highest concentration of platelets were those that were most effective, again, in stimulating hair growth. Next. But we did a study that was published recently as well, showing that there wasn't really a direct relationship, again, between the type of PRP that you use or the platelet number, and again, the activity of the cytokines that are stimulated. Next. And here are just some examples of some patients. Next. These are after 3 treatment sessions. So we do 3 monthly treatment sessions. And then if the patient, we usually switch then to every other month. And the major cocktail that I use in my practice is PRP, low energy light, which I usually start with 8 weekly treatment sessions, and we'll come to that in a moment, and then start separating those out as well. And now oral minoxidil. And that's really the major, again, intervention that I utilize for the majority of patients with hair loss. If they have significant inflammation on biopsy, then sometimes even with the oral minoxidil, I'll have them use some topical minoxidil compounded with a medium potency corticosteroid lotion. Next. The newest area that our research group is now looking at is a sort of a somewhat controversial area. The FDA is examining this very carefully. It shouldn't be used in clinical practice yet, only for research or IRB type of indications. And we're looking at 2 exosome type of preparations. And these are sort of vesicles from stem cells. One of the companies has from placental stem cells. And again, these contain growth factors, peptides, and messenger RNA that's similar to PRP, are again felt to be stimulatory. Some individuals that are using this in their clinical practice, it certainly is off-label. The FDA has not, again, given its okay for it to be utilized, state that it works a lot better than PRP, but the answer really is not in. It's really in the earliest phases, similar to the early phases of PRP. So stay tuned to see how exosome treatments compare to those of PRP. Next. And then low energy light, we published several studies. I like using an Omnilux type of device, but you can use any in-office device that, again, surrounds the entire hair. And again, we usually do a single treatment, 8 treatments done on a weekly type basis. And then we do every other week, then once a month, then every 3 months. Many of these patients also use an at-home red light source as well. Next, low energy light or red light. Next. And again, we did several studies with the University of Minnesota looking at all of the at-home light devices. And if you can see the next. And we showed in this, again, study that photomodulation does work, but there's not really great significant studies, excellent clinical studies that have been performed. And all the studies that are out there are sort of a lower class 3 or class 4. So we need some better studies. The mechanism of action of low energy light is felt to be stimulation of the cyclic AMP and mitochondrial pathway. And again, increasing cell function, that stimulates the stem cells in the hair follicle. Next. And here are some low energy light patients from our studies. Next. And all of our studies now have this, again, computer analysis of their hair growth, again, hair width, number of anagen hair follicles. And again, that's how we monitor our patients now in 2021. Just quickly to talk about, go back, talk about some of the, again, technologies that we're utilizing: microneedling, fractional lasers, fractional radio frequency. And what I'd like to emphasize is mechanical scalp cleansing, which I'll talk about in a moment. Next. Again, this is microneedling with PRP, a somewhat controversial area. Some people feel that using microneedling before application of PRP may actually close the channels after the microneedling is performed and not allow the PRP to, again, if applied topically, to penetrate as well. If I do microneedling, I usually use a combination of topical and injectable PRP. Next. And here's some excellent results looking at this combination type of approach. This patient came to me, she'd been around to 8 different dermatologists in 8 different countries. She lives in Africa. So I think that the combination of PRP and microneedling can be effective. But again, you want to be sure that PRP is applied almost immediately. Fractional lasers, we can go to the next slide, also have been utilized. Their mechanism of action, similar to fractional radio frequency, is creating these microdermal wounds. They can be utilized as transcutaneous channels to apply either minoxidil or PRP, or by itself. Again, they can also stimulate or upregulate the dermal remodeling cascade of the stem cells. The problem with these technologies, we go to the next slide, is that the wound healing response only lasts several months. So again, you need to repeat these types of procedures. We can go back one. And again, it's a fractional laser. And then moving on to PRP can be applied after the fractional lasers, or the fractional lasers can be used by themselves to, again, create subclinical wounding and upregulation of stem cells. Here again, you can use topical growth factors as well, as you see here. And this is a new device that we're working with. You can go back. And this is called, again, the Glow. And it's a sort of scalp cleansing device where we apply topical growth factors, and it actually has a vortex type of technology that allows you to cleanse the scalp, and then you can apply various growth factors or minoxidil preparations immediately after. So I think this is part of the new concept of hair health. And that's why I was mentioning that we use this in all of our inflammatory scarring hair loss patients, and also in most of our genetic hair loss patients. Of course, one of my, again, targets is to decrease inflammation. And by keeping the hair follicles patent, decrease organisms, decrease inflammation, I think that's another adjuvant part of the program that we can use to treat hair loss. Next. And here you can see the cleansing and growth factors being applied. You can use PRP as well, and minoxidil topical in addition to this. Next. So we have new generation technologies. We have microneedling, energy-based devices, PRP protocols again, and combination efficacies are usually additive when you use multiple of these types of technologies together. We still need better consensus recommendations on treatment protocols, and we're also doing that for PRP now. We're looking to see a comparative, again, to see whether 3 monthly treatments and then waiting 6 months and not doing a treatment is better than doing 3 monthly treatments and then doing every other month treatments, to try to get some more information about the optimal treatment protocols with PRP. Next. And that's it. Thank you very much. We have one more lecture. Any questions, Wendy? Any questions, or Val, or for anybody?
It was great. You really put it all together. I like the Canfield. That's it. That metrics.
Yeah, I recommend for all of us that are involved, and Jerry Shapiro and I helped develop this with Canfield, that it's cost about $12,000. So and you could probably negotiate the price somewhat as we did. So I think, but it's something that's really helpful in monitoring the patient's success with any of the treatment modalities, rather than just doing, because it gives you extremely close-up photography. It gives you, again, exact hair counts, gives you the number of, again, indeterminate hairs, number of vellus hairs, the number of early anagen or thin anagen hairs, and regular anagen hairs. So it gives you a lot of information. And I found that when I go over this with patients at 3 to 6 month intervals, it really gives them a lot of support and satisfaction and security that their treatment programs are working or occasionally not working, but at least we have some objective information.
Yeah, Neil, I agree. I just got it in my office too, and I've only been using it for a couple of months, but it's very easy to use. It gives a lot of valuable information.
Right.
So that's, yeah. Mhm.
It takes some time and you have to have somebody devoted to it. Some people complain it takes about an extra 20 minutes, 15 or 20 minutes to do, but it really is helpful in following patients and giving them a sense of security, particularly if you have them on multimodality programs as to whether or not the programs are working or not.
Yeah, just give it to a medical assistant.
There you go.
You know,
Right.
that's what you do.
We have
All
a
right,
competitor and we make it a separate appointment, completely unrelated to when they're.
You
when
can
they're
do that
seeing
as
you.
well. So is anybody working with either, again, looking at the Glow or with the Hydrofacial Keravive, the scalp device? I really recommend, if you're into really having a complete hair practice, that you look at that as well. Because I think that, again, cleansing of the scalp with water, and again, opening the ostia, the pilosebaceous units, keeping the hair follicles patent and clean may decrease microinflammation. That may be very helpful. So we're really incorporating this into most of our patients, particularly those that have inflammatory alopecias.
Yeah, and I
We've had
agree,
the
Neil.
Keravive for about a
We
year.
actually did the clinical studies for the hydrofacial.
Are you
And,
using it on your
Thank
regular
you.
patients now, Bella?
No. But now I will. But we did
Right.
the studies though, and we saw great results with it too.
They
So,
are.
yeah, yeah.
I think a new concept is hair health, and that's something that we might all consider. Okay, let's move on quickly. I know the time is late, to some hair transplantation, just to give you an update next.
Oh,
So
good.
we've been working with the Artist robot. You can see my disclosure here with the Artist robot, for which now can be used to remove follicular units as well as implant into the recipient site. And we just started working with it several months ago. We've been working with the NeoGraft now for about a year and a half. So we have a reasonable experience. Here you can see the global hair restoration market is also extremely big. It's extremely competitive. Marketing plays a major role. Individuals that are just involved with hair restoration surgery. But we gave a course at the AD this past week. I think that dermatologists should not let hair transplantation escape them, as we have with other areas like liposuction or the treatment of venous disease. It's not that hard. And Wendy, you do hair transplants, right? You said, Val, are you doing them or anyone else doing them?
Love it. Love it.
But I think it's something certainly that can be mastered by dermatologists quite easy. Next. And there are two types. Again, you can either do a strip or you can remove follicular units either manually by a machine with the NeoGraft we'll talk about, which is a suction device, or with the robot. Next. And some people still like using strip or FUT because they think that there's greater density. But I think that, similar to what robotics were in GI surgery and other surgical procedures, I do think that's going to play an increasing role, because having worked with both or the three, again, mechanical hand pieces, engine hand pieces, the NeoGraft and the robot, I think the robot gives you the most precise, ability to remove, again, consistent follicular units, and also with the implantation technique that's now being improved. Next. So again, this just shows you that less people are doing strips, removing strips, and more people are doing follicular unit surgery. Next. Next. And you can see these are the two major, again, units that are out there. It's the suction device that's motorized. I use it with suction, the NeoGraft, or the Artist robot. Next. And here's the NeoGraft again. And it's been around for a while. It's a suction removal device, again, that allows you to collect the follicular units into a suction tube that goes directly into a holding solution. Next. And one thing, as you can see here, is that the grafts are passed again through this tubing into this holding solution. It takes a little bit of skill to be able to utilize this device, because you need to angulate the removal of the follicular units. So I'm working with the company now to try and make it easier so it can be just a straight, again, removal of the follicular units that I think will really make it a lot easier to use. Next. And here's the procedure, as you can see here, harvesting. And again, you also need to have a good eye. You need to use, magnifiers as well, because you want to be sure these follicular units are not transected, and you need to go at the angle of where the hair is exiting from the donor site. And then you can see the implantation can be made by a needle. Next, it can be made by the needle graft as well, but that's very tedious. Most people don't use it for implantation into the recipient site. They still use either a small microblade or a needle for the implantation of the recipient follicular units. Next. Next. Go to the next slide. Okay. And here's the neograft extraction handpiece again, but we are working on a newer one that's going to be a lot easier to use. Next. And here you can see the harvesting and the grafts going up into the tubing. It's almost like riding a bike. Once you get the technique down, the major issue is getting the angle of removing the follicular units. And here you can see the follicular units in the holding solution in the canister. Next. And there also is an implanter handpiece that can be used to put the follicular units into the recipient site. However, most people are not using this. Next. Including myself, are not using that. Here's a graft implantation. It's a Choi implanter. You can use any type of implanter. Here's again the implantation sites being made. Next. And they're implanted usually by a stick and implantation, where we remove the follicular units, and then we have again 2 assistants that implant these immediately post-op. Next. Immediately, after they're removed from the donor area. These are 3 days post-ops, similar to other, follicular unit transplant procedures. There's some small micro crusts that occur. We don't use bandages on any of our hair transplantation patients anymore. We leave them in the office for 30 minutes to be sure there's no oozing, and then we send them home to relax with their head elevated that day. Next. Here's some clinical results. Next. Next. And here's the robot, the ARTIST robot. And again, it's the first computer-assisted surgical procedure in dermatology. And the FDA indication at this point is only for men with dark straight hair, but we're looking to get an indication for women as well. The limitations of this, they haven't perfected its utilization in the occipital area or crown area as well, but the company is working on that. And again, the ability to get an indication to treat other hair types other than dark straight hair. Next. And here you can see the machine. There is the, again, removal punch that's in the, again, ARTIST robot itself. It's really actually quite easy to use. And again, what I found is that the graft quality is very consistent. If you work with an assistant that examines the follicular units immediately as we take them out. Next. It can be extremely consistent in terms of the results. You can also do, again, a photographic planning of particularly of the recipient area, and you can, again, create a specific pattern that you want to implant into the recipient area. Next. And here you can see me behind the robot using we use local anesthesia, then some tumescence. You want to have a turgid type of area. You can see the robot there working on removing the grafts, and then at the same time, the grafts are being removed, as you can see here, by an assistant. Once the robot makes, again, the incisions. Next. And we have to trim the hair. That's the other thing. You need to trim the hair to 1 millimeter or less for the robot to be able to recognize, again, the follicular units. Next. And you need to trim the hair both in the donor area as well as the recipient site. Here's the tumescence being applied. Next. And again, one of the 2 newest parts of the technology is this 3D preoperative planning, where we can actually create a plan, particularly in the recipient area, exactly how we want the follicular units to be implanted. Next. So it's extremely consistent. Here you can see again, we have these tensors. You see that yellow sheet there, that's a tensor that allows recognition by the robot of the area where the follicular units are. Extremely precise. It will not remove, again, any parts of skin or hair follicles that are not, again, intact. So the transection rate, and we did like 10 cases 2 weeks ago, and we had a week of training some of the aides that help some of the with this procedure, and the rate of transection is extremely small, at least compared to what I can do with my hands using a motorized engine in the past or with the NeoGraft. Next. And here's post-harvesting again. Okay, and then these are recipient's incisions, which usually make with a 18 gauge needle next. And you can see the implantation. We usually have a team of 2 working with us on this, but now the robot, again, the new generation of the robot can actually put the follicular units in place. And this really is the most tedious part of the procedure. And it's still being perfected, but we worked with it last week. And it appears that this automated implantation into the recipient area is actually quite accurate. And I think will be a major, again, advantage of using this technology moving down the road in the near future. Go back one. Here's a patient a year after one of our earliest, again, robot transplants. Next. This is another from another center here. Next. Jim Harris is one of the innovators of this. Next. Next. So I think that, you know, robotic aesthetics is here to stay. This is the first, again, new technology for hair restoration surgery. The company is also working on robotics to remove skin and actually do non-surgical skin tightening. They're also looking for robotics for implantation of botulinum toxin, as well as for fillers in a more precise fashion as well. And again, a combination of again, follicular unit, hair transplantation, and PRP combination really is the major way that we treat our patients. And some of the other factors we've talked about are also very good for maintenance. But I think robotics is in the early stage. It's going to continue to develop. So be on the lookout for its further part of our armamentarium. And most importantly, I hope that dermatologists will take the time to attend courses at meetings such as this, or at the AED, or at the ASDS, or the International Society of Hair Restoration Surgery, and really consider incorporating into the practice. And because I'm sort of passionate about this, I'm also setting up a research center. So if you're interested in learning this technique, if you just give me a call, we'll see if we can have you come in and do a couple of cases. Thank you very much.
Excellent.
Thank you, Neil, so much. So informative. And I love the research center part. Are there any questions? Does anyone have any questions? If so, get off of mute and we'll be on for a minute or so to any follow-up questions?
Yeah, I have a question for the artists. Did you say there's upgrades coming? So we shouldn't purchase one right away?
No, the upgrades you're hearing now that have been recently been released, you know, so it now can do the donor extractions as well as recipient implantation. So you can actually make the follicular unit recipient sites with the machine, and it will also put the follicular units in place as well. So now's a good time to get on board if you want to be one of the earlier innovators, because this part of the technology was just released about 6 months ago. I mean, one thing, hair restoration is a whole nother part of a practice. You need to be sure you have enough patients to do the procedure, you know, to pay for the cost of the machine, which I think they're trying to lower the price of it so it's more affordable. That was a major issue of it not being utilized by most of us, including myself. But, you know, finally, and I paid for the machine, so I'm, you know, just so everybody knows. But I think that I wasn't really convinced that it was going to make a major difference compared to using a hand engine or the NeoGraft, which I've been working with a couple of years. But now I have both in my practice, but I rarely ever use a NeoGraft because I think that the quality of the grafts and the consistency of it in terms of transections and the ability of the robot, the new generation of it, to be able to recognize where healthy follicular units are, you know, is really much advanced. And again, the hardest part for me was putting the grafts in place, the follicular units in place. And we used to have to bring in 2 or 3 people just to do that. And there was a cost about that as well. So even though there is disposable costs for, again, the robot, it's actually turned out to be financially a lot more beneficial for myself. And once you get past the first, 20 cases, the machine sort of pays for itself after that.
What about the curved follicle with the robot?
Yeah, that's my question. How
Oh,
do you
sorry.
deal with, yeah, no, that's okay.
So
No,
the
I'm right
company
behind
is,
you.
it's not perfected that aspect yet. As I said, just really straight dark hair is really the major component that's being, but they are working at that in Seattle. I mean, to be honest with you, I'm really impressed. If you're interested, the artist company, which was purchased by Venus, is out in Seattle, and they really have some really bright engineers working on this, but they still need to work on the ability to treat curly hair. So most curly hair cases that we do with the neograph still. Those are the only cases that we use the neograph rather than the artist.
Mhm.
So
I
Neil,
call it
do you know,
Author. That's what I named the robot. My robot's called Author. So
do you know if what's the difference between the NeoGraph and the Smart Graph?
they're very similar.
Okay.
And the technique is very similar. As I said, though, there's some technique involvement with removing the follicular units. You have to angulate, again, once you make the motorized incision, to remove the follicular unit without, again, traumatizing it. You sort of have to angulate the follicular unit out from, again, where the incision is made. And I think it's sort of difficult for people. So that's why I'm really encouraging them, which you're working on right now, to create a straight type of smart graft or neograph. So you make a very straight incision, so it'll be super easy for anyone to use. And the other area where the robot hasn't been perfected yet is to be used, again, in the temporal areas here. So sometimes we need to combine using, again, a manual punch to, again, if I'm going to do the sideburns or the areas right on the anterior hairline. And in the occiput now, I'm working with the robot to try to perfect the results. And I think that's very, very short time in coming. And I think now's a good time to get on board if you're interested, because I think, the company wants to do well. So you probably can negotiate a good price with them if you're interested. And, because you're all friends of mine, if you're interested in it, I'll try and help you with that negotiation. I don't have a lot of negotiate, but I know the owner of the company is the owner that started Cineron as well, and now runs Venus. So, and they're very passionate about bringing, again, hair restoration into the dermatology world. So, so I think that now's a good chance to get on board. So, and I think robots, the same thing happened with the Da Vinci robots in surgery. People didn't believe it was going to play any sort of a role in general surgery by itself, and now it's sort of the standard of care. And I think as we move forward, robotics is going to play a major role in aesthetic dermatology.
Well, I think you're right about us not missing the boat on this and really owning it, because it is our specialty.
And you're doing transplants, Wendy, right?
Yes, I have a
I mean,
neograph.
what I would do is, you're doing the neograph?
Mhm.
Okay. Do you do it yourself? You do it, or do you have, because the neograph assistants, they had assistants coming in to help. That still can come help, but really the government state regulations want the physician to actually remove the donor sites, any of the cutting that's involved. So they're going to stop having people helping to remove the donor sites. It's still an excellent procedure, but I think, it's also really good to learn how to do it ourselves and not
Well,
be dependent on everybody else.
for the big cases, I will do FUT. So
You're still doing
yeah,
strips.
to cover a lot of area. And I liked your slide because there are benefits. We're all FUE, but when you have to cover a lot of area, and if you have a patient who needs to be done quicker, FUT is a quicker case.
I mean, we need to, I think that's right. Or if you want somewhat greater density quicker, that's still an option, but there is a scar. But now the new technique of hair restoration surgery with FUT is not trimming the hair and not trimming the hair at all, and actually removing follicular units or removing the strip without actually taking down the hair.
Taking it from the strip.
Called long hair restoration surgery.
Yeah, I mean, there's a lot. We'll have to talk about that at the live meeting, because there's a lot in that. We could talk about hair for all days.
But what I decided to do is start a training center, because I really want more dermatologists to get on board, especially those of you that are really interested in hair. I think it's a great adjuvant to your practice, and it's something that when you talk to patients and you see the results, even in women, I probably do as many women as I do men. I think that it's super really helpful.
Yeah, I think we need to discuss it a lot more with our women. A lot of
Yeah.
women don't think of themselves as candidates, so.
Right.
Now, we have a lot of people still on. Does anyone have any questions? What a group.
I have a
All
question
right.
for Dr. Kogan. Oh, does someone have a question?
Nope.
No. So Dr. Kogan, my patients are pretty sharp and they find out stuff before I do. And so one of them found the DHT only blocker or the DHT only inhibitor.
Mhm.
And sorry if I missed it. So what would be the reason they wouldn't just take the core Nutrafol because it's already in there, that they would just use that DHT inhibitor?
So are you talking about a DHT inhibitor that is manufactured by Nutrafol or?
Yeah.
Oh, okay. So there are a couple of boosters that are that you can only get through the quiz online. And you know, we're actually at the process of kind of reformulating and establishing that whole process right now. And though you're actually, your patients cannot get, nobody can get the booster on its own. It only comes as a supportive. So they are boosters for a reason. They're not sold individually separately. They can be sold individually in your offices, but they're not sold individually online. So they can only be used in conjunction in this process called the growth plan, which is something that we have on our consumer side. But we took the most successful boosters and we recreated them and reformulated them for physicians. And those are the ones that I was talking about in my lecture.
I guess what I'm asking is like when the patient does the questions and they have that DHT blocker booster, I don't know the name of it.
Yeah,
DHT inhibitor.
Yeah, it's a booster.
Yeah, what determines if they get that versus the core because it's already in the core?
Well, no, it's an additional one. What I'm trying to say is that there's no boosters that they're going to get separately. So if they round up, if they're a woman, and for instance, they had, you know, there are several core, I don't remember all of the questions, but there's an algorithm that basically counts on the back end. According to specific questions that they're asked, maybe they have, you know, they possibly are a woman that has, you know, facial acne or like, or has, you know, what we ask about oil, we ask about, you know, greasy hair loss in specific areas and things like that. So if they're answering, or maybe hypertrichosis, so like if they're answering in that particular way through the questionnaires, then they may get an additional DHT booster.
That's why. Okay.
Does that make sense?
Yeah, I'm trying to figure out why were they also getting more?
No. But in our core formulas, what we do is we, you know, the amount of the supplemento and other ingredients is really determined by the particular formulation. So if the men's has more supplement or more DHT boosting capacity, and of course, you know, you are the ones who came to us and said, oh, you know, this is what are we doing for menopausal women, and why does it work better? And so we created the menopause formulation to also have more DHT inhibiting properties. So both of those formulas actually have that built-in kind of booster capacity.
I have a couple of last questions. Do all of our panelists or experts feel that PRP is a real thing? Does it really work for patients?
Absolutely.
sure.
Everyone's convinced. I'm
Oh,
glad
yeah.
you're. Anyone have any early insight about exosomes?
Yeah, I've used 5 now because nobody could tell me which one was the better one. And the one that's really expensive in my hands is not helping with CCCA. And then there's one where they sell 100 billion and 450 billion. I get better results with that one, and it's the 450 billion that I'm getting better results with, and it's cheaper. And then I'm now about to dabble into the company that sells up to only a 12 billion. I'll keep you guys posted on that.
I think it's sort of important, and that's why I haven't really gotten involved yet until we get, you know, and some IRB studies or INDs about it. So I never like to use anything on my patients unless there's reasonably good clinical data about it. So, but it's an interesting area. I just think it's so embryonic now, and we have to stay tuned.
It's very early. Yeah.
I agree. I have heard the very similar things. My experience, I used them a couple times. I wasn't impressed. 2 different companies. didn't know if I was getting the result with the PRP or the exosome, you know, what's going to perform better. And then I feel similar that the quantities are just kind of all over the place, and it needs a little more, little tighter, needs a little regulation.
Yeah, and I agree. I don't have any experience with using them at all, but I'm waiting for some clinical studies and some, you know, some good scientific data.
We're writing up a case report. You know, with the volume I have a decent cohort of pretty desperate patients, which is why I was able to do so many. And we'll publish what we've done so far, but there was definitely trial and error because definitely nobody's doing it in CCCA, which we are. So if it helps, the one that's 450 billion is the one we seem to like. But of course, now they're raising their prices.
Isn't hydrofacial using Carafactor?
No, LazeMD by Lutronic is coupled with Carafactor, so they call it Caralase. Hydrofacial will deny that they're using Carafactor, and they say it's their own proprietary growth factors, but it feels and smells very similar to Carafactor.
Yeah.
So I'll tell you a little secret. When we use these devices,
Carafactor.
we use water. I think water is the major factor of keeping the hair follicles patent. And sometimes we will use something that has good, you know, biologic activity, like Rogaine, up to 7% applied right after the treatment. So I just feel that there's not enough information to see whether that's helpful. But I do believe that
excellent.
the hair follicles.
Can you use green tea?
You can use green tea. We have to start a whole, we should get a group together here and create our own recipe or cookbook. We'll call it the Caravive or Glow cookbook. So, but I think that's an area that still, you know, is under development now, the concept of hair health, that we shouldn't take too lightly, you know, for our patients. Because you know, as you know, Val and Wendy, that inflammation really has been a lot of emphasis of the research that I've done over the last several years. So.
Yeah. Neil, are you
water.
recommending infrared light as sources for your darker skin, brunette haired patients?
Yeah, I use, again, low energy light, usually red light somewhere between 630 and 833 nanometers. I do believe that's, you know, super helpful. I actually think it's a better anti-inflammatory wound healing light, but it also is effective in hair. And there are enough studies in the literature again. And now that we're getting more data over this year, you know, looking at, again, the artificial intelligence device to follow these patients and have some more information, because it's still a little bit of an unknown as well. Brock Sanderson has spent a lot of time, and he feels that the upregulation of mitochondrial activity is the mechanism of action. But, you know, and then Rhonda did the study of 20 different at-home helmets and didn't find any particular efficacy of one over another. But I believe that the higher intensity in-office light, if you're going to do light, if you can get the patients to come to your office, is really a good way to start, a better way to start. But we need more information about that as well.
I've been concerned, though, about some of my type 4, 5, and 6 patients with their skin possibly taking up the energy from the light and actually getting overheated.
I've not seen that to be a problem in my practice. I have a Latin wife who's dark skinned, and we have a tremendous number of skin types 4 through 6, African American and Hispanic individuals, and we use a lot of light on them. I've not seen that to be a problem.
Okay.
Is it not FDA approved, but is it indicated for the darker skin types? Because I thought it was not.
I don't think there's an FDA indication for that, but
Right.
I've not seen. Have you seen any problems? Maybe you can tell me. I've not noticed any problems in treating. We treat all skin phenotypes. I've not seen any problems with low energy light. But it could, you know what I'm saying? I've not seen it. Have you seen it, or?
No,
you
I
can
haven't seen
educate
it.
myself.
Yeah.
But it could be a theoretical concern at least. I think the important thing is to try to keep hair in the dermatology world. You know what I'm saying?
Yeah.
Promise me we won't let it get away from us.
Mm-mm.
Yeah.
I have a
Absolutely.
quick question. How do you deal with, you talked about hydrofacial and cleaning out and like protecting from inflammation. And then on the other side, of course, there are some people who cannot, you look at like protecting the hair structure, the follicles and things like that, and not depleting of oils or stripping of oils. So I'm just curious, kind of like, how do you find a balance,
I'm not sure that water by itself has a significant deleterious effect unless it's very hot water or water that's desiccating, to the hair follicle itself. And it's interesting with the second technology, the glow, it's actually more gentle on the scalp than the hydrofacial Keravive is, and that's the one I actually prefer now. And Salima, who's my wife, does a lot of these treatments in the office. So I haven't really found it to increase irritation. We use it also for individuals that have seborrheic dermatitis, and we use
Yeah.
and mild psoriasis. And the reason I got started, looking at the role of inflammation, so many women that came into my practice over the years were complaining of burning scalps, red
Right.
scalps, and it had hair loss, and sort of the discomfort and symptomology was way out of line with what I was able to see clinically. So now that's how I started, but now I biopsy every woman that will allow me to that comes into my practice. So, and we have, probably over 500 biopsies now, and we're putting together the data. We published a couple of papers to show probably about 1/3 will have significant inflammation on their biopsy. And it's very consistent, lymphocytic inflammation around the bulge bulb, and then IgM, immunoreactivity in a granular pattern.
When we're talking about washing the hair, it's about frequency, but this procedure is once a month for about 3 treatments. I don't know if Neil's protocol is different. And then it's about the ingredients, particularly if it is heavily sulfated and stripping, but that's not one of the ingredients in the procedure. And even our stylist now does the Keravive, and she's very particular about Trichorexis nodosa, and she's not seeing it.
Yeah, I've seen it. I've seen it like used in even in hairstylists, by hairstylists. And so I think there was one hair salon that was doing that in New York, and I was just curious. But I think frequency is my question, really. It's like
Once a
how
month.
often, yeah.
If
Wait,
you
a
look
hair
at
salon has it? I'm getting rid of it.
if you look at the schmutz that comes out of the bottle after these
Oh,
treatments,
it's
Yeah.
my favorite
Oh, I
part.
know.
it's hard. That stuff cannot be healthy for the hair.
I can tell you an at-home treatment that Diane and I have offered for our patients and that they have liked is Patty Powell's Restore C scalp solution, which has the
Oh,
live enzyme, the aquabutene. It's a nice way to really an astringent for the scalp in a very controlled way for someone who's got a protective style, is not washing their hair more than once a week or once every 2 weeks. I'll have them by day 4, after having cleansed their scalp or shampooed, begin to use the Restore C, on a Q-tip on their finger to really help to prevent the breakup of or the buildup rather of keratin and scale and oil, because it can also be used on keratosis pilaris. It can be used for very oily acne patients. It's a multi-purpose use in our practice, but it has been a nice way to keep the scalp cleansed in between shampoos.
Yeah, and I agree with Eva. I like it as maybe almost similar to like a dry shampoo. So if somebody has a hairstyle and they don't wash their hair frequently, they can use it on their scalp, almost like a dry shampoo, just to exfoliate. And it's very gentle. There's no stinging associated with it.
Yeah, I use it as well. It's a good to bring that up, Eva. It's a good product.
I'm gonna start using
It's
it
way
now
out.
after
Yeah,
this.
I mean,
Googling
it's
it
wild.
now.
She's really out there on the forefront of
Yeah.
of hair health. And
We can start a hair club
hygiene.
with all of us, you know what I'm saying?
I think hair health is a very interesting and different topic, because there's a preventative aspect to it as well.
Right.
And And I think we're just also at the brink of like at the tip of the iceberg. Like that's always my question. When you clean, do you take away the microbiome? Like what is good?
Well,
What is
that's a
bad?
study
What's
that
the
Minnesota
balance?
is looking at that effect also in one of their studies that we're
Right.
doing. We're looking at they have actually one of the world's top PhD microbiologists on microbiomes. So one of the studies we're looking at is alteration of the microbiome, both with PRP as well as with these cleansing devices. So that's
Yeah,
just.
I think that's super interesting as to like how much are you taking away the bad bacteria, how much is being left, and like the preventative aspects of hair health in general. So I love these lectures. Thank you. Everyone has really been very incredibly insightful.
Thank you for including me, and to be with all my friends made my night special.
Oh, I'm so glad
Oh,
everybody
Neil.
could make it, and that's what it's all about. So thank you all. And we'll see you next month. Next month is September 14th, cosmeceuticals and chemical peels. With
Perfect.
another group of experts who blow us all away, like this group.
Okay.
Thank you,
All right.
everyone.
Good night, everyone. Thank you, Wendy. Thank you.
Yes.
Wendy, thank you.
Thank you.
Love you.
Love seeing you all.
Bye, Dr.
See you.
Calendar.
Bye.
Thanks,
Bye,
everyone.
Shanna,
We're
Sophia,
staying on.
Neil.
We still have 22 people. Yeah.
Dr.
All right.
Sadik, I would love to come up to your,
You're in Washington, right?
yeah, in Maryland.
Yeah,
Why don't you just
Shoshana,
call me,
let's
you know?
I
drive
can't
up.
get too
It's
close to
just
Dr.
an
Calendar. I'd never
No,
be
we'll
so
take
close.
we'll take the Amtrak.
away, right?
Yeah,
It's a
we'll take
train
the Amtrak.
We can
They'll
have
make it a,
we can have a ladies'
go to
day in New York.
Amtrak there.
We can spend the day treating hair patients, and we'll go out to lunch or for outdoor happy hour.
That'd be
Straight
great.
Yeah,
away,
let's
I'm
do it.
coming.
Let's do it.
Let's do it.
Yeah.
Just pick up time. Just text me tomorrow. We'll pick a day, in the next few weeks.
Perfect.
My
Okay.
office manager is getting married in 2 weeks, so maybe right after that would be a good time.
Yeah, yeah. Okay. Well, thank you very much
Thank you
for the
very much.
invitation.
Bye.
So great.
Okay.
Well,
All right, you guys.
Thank
Good
you so
night.
much. It was so wonderful to
You can
see
see
you
the
all.
robot. You can see some of the other things. That'll be a great idea because, again, to pass on the word to all of dermatology. All right, have a good night. Bye.
All right, good
All right,
night.
good night.
Good night, everyone.